هدي المحاضرة.
بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته، أحييكم في هذا الصباح الجميل في اليوم الثاني من المؤتمر، مؤتمر المدينة الدولي الثالث لمستجدات التأهيل الطبي. بداية أرحب بزملائي مدراء الجلسة وأرحب بكم جميعا. نبتدئ جلسة المؤتمر. Our first speaker is Dr. Safa Jambi. She is Vice Dean of Student Affairs at Taiba University. She was Vice Dean of the Dental College. Dr. Safa holds PhD and clinical MSc with distinction in orthodontics from the University of Manchester. M.Orth from the Royal College of Surgeons of Edinburgh, and she has clinical experience that is reinforced by working in diverse hospitals and clinics in Saudi Arabia and in the UK. Lecture title is Rehab or Prehab, Teaching Interceptive Orthodontics to Dental Students. Would you please welcome Dr. Safa Jambi.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the very nice introduction. I'm very happy to be here. Today I'm going to talk about teaching interceptive orthodontics as a prehabilitative procedure. And just because I know that it's a mixed audience, I'm just going to start really quickly by letting people know what orthodontics is. It's the branch of dentistry that corrects teeth and jaws that are positioned improperly. In the last conference, I talked about how orthodontics, how we can use orthodontics in rehabilitation, in oral rehabilitation of patients. This year, I'm going to talk about something a little bit different. And in case you don't know, you still don't know what orthodontics is or who orthodontists are, we are the people responsible for this kind of smile. But today, I want to talk about interceptive orthodontics. It's the treatment procedures to lessen the severity or future effects of a malformation and to eliminate its cause. So it's more of a preventive, or you might think of it as a prehabilitative procedure. And when I talk about prehabilitation, I mean that it's a preoperative thing that you can do in elective cases with the aim of reducing complications, shortening length of stay, and improving functional capacity. Prehabilitation focuses on reducing risks and complications of planned procedures and enabling lifestyle changes. What I'm going to talk about today is my research on interceptive orthodontics and how it can be used as a prehabilitative procedure. I'm going to talk about 3 researches that I've done, and the outline will be as follows: the background, the objective, the methods, the results, and the conclusions. So, interceptive orthodontics is considered prehabilitation because it focuses on reducing risks and complications, decreases the need and complexity of comprehensive orthodontic procedures, and can shorten the length of comprehensive orthodontic treatment. Now, the problem is interceptive orthodontic procedures are usually needed at a younger age, around 7 to 10 years. And this is not the age that we usually see at clinic as orthodontics. This age group is usually seen by a general dentist. Therefore, general dentists play an important role in detecting and managing interceptive cases. So, the question here is, can senior dental students and general dentists recognize and manage interceptive orthodontic cases? And what I'm really talking about here is the knowledge and clinical reasoning, or what we call on clinic diagnosis and management. So the objective of this research is to assess the knowledge in interceptive orthodontics in senior dental students at Taiba University, and also for recent dental graduates on a national level. And also to measure the impact and engagement of dental graduates to an outreach social media program, and to assess the effect of certain variables on knowledge in interceptive orthodontics. So there's 3 main methods. Some of them are more scientific than others. It started out with action research, in which I collected qualitative and quantitative data. And then I had a little bit of an experiment with social media, and then cross-sectional research. All ethical considerations and approvals were obtained as needed. Now, with these different types of research, I believe I've reached triangulation in research methods and also in the results. So let's start out with the action research. What is action research? It's education research, and it's designed to diagnose problems or weaknesses and help educators develop practical solutions and address them quickly and efficiently. So it's something you do in the classroom, and it gives you really quick results. And action research usually follows a cycle. So there's usually a starting point when somebody, either the teacher or the student, notices that there's a problem in the learning experience, and that develops into a question, followed by planning, and then taking the action, analysis, conclusions, and then reflection. And upon reflection, you might get another question, and you can start that cycle all over again. So what I will do, I'm just going to go through this cycle and tell you what I've done on my action research. Dr. Nada Saidi helped me with this action research. She is one of the graduates of the first batch of students who graduated from the dental school. And as you will see later, she helped me with the questionnaire and with distributing the questionnaire itself. Right, so what was the starting point? My starting point came from the students and from myself as a teacher and as a clinician. So this was about 4 years ago when we were teaching people how to manage interceptive cases. So they had to bring cases on clinic, they had to diagnose them, and they had to manage them, and they had to treat them. The problem is there wasn't very many cases, so it was very difficult for the students to find suitable cases. So what happened was 3 of the students came to me, and I was the course coordinator at that time, and they said, we are really having a problem finding patients, and we're really afraid that we're not going to learn on our clinics. The other thing that I noticed was that I teach the senior dentists, so this is their last year before they graduate. And I did notice that they were much better on their psychomotor skills than their clinical reasoning or their diagnosing skills. And also on clinic, I noticed that I had patients that came to me with very comprehensive cases that could have been managed really easily had they come earlier. So all these three things together developed a question that I started with on my Axon research, and it's how to enhance the clinical reasoning for interceptive orthodontic cases. The planning phase. So we decided to move our lesson from the clinical setting and go to school classrooms, so we can see a lot of patients at that age and perhaps be able to diagnose cases. At the end of this, I decided to distribute 2 written clinical vignettes to the intervention group, which are the students who are going to go to the schools, and a control group, which are the interns who already graduated but didn't get to go to the schools. The ethical issues that we had to deal with was consent of the actual school children that we were going to see and informing the parents. And we obtained required permissions either from the school that we were going to visit and the university. And we had a timeline from 2 to 4 weeks to finish all of this, but we managed to finish it in 2 weeks. And then we had to set up some systems. The school was going to obtain the consent. I developed a flowchart form that helped the patients reach a diagnosis and also just general management. And the management in this case was either no treatment needed, or refer to a specialist orthodontist. We designed a parent information form to let them know if their children had anything. And obviously, we had to get some armamentarium, such as gloves and mirrors, and take with us to the school. And that was the planning phase. And then it was the actual action phase, which was the school visit, in which I collected qualitative data. The school visit, we went to the school and we saw year 3 and year 4 students. The whole class came with me in each. We had 3 of our students in each of the class, and they did like a screening to all of the patients to see if they had any interceptive problems. If they did, they would fill out a form that would inform the parents, and they would also diagnose it and decide a general treatment plan. A month later, we distributed vignettes. These vignettes are a clinical scenario and some questions on them. There were 2 vignettes, one on an interceptive canine case and one an anterior crossbite case. The analysis. So observation, and this was a very, very beautiful thing. We had 2 to 3 students per class, as I said. Each class had 20 school children. So that means each of our students got to see at least 6 school children, or if you want to call them patients. Now this is very important because on our course, the students would only see 1 patient throughout the years, whereas here they got to see at least 6 school children, and many of them did have interceptive problems. And if it was a 2-hour visit, and it was a very, very busy visit, at the beginning of the visit, our students would ask us lots of questions: how to seat the patient, how to manipulate the mandible, what should we do here? By the end of the 2 hours, and I'm being very honest, they were just doing it by themselves. They were looking at them, they were examining them, they were diagnosing them properly and filling out the forms. So within these 2 hours, they learned as much as they would have learned in that whole year on clinic. I also have quantitative analysis. We distributed the vignettes. So in the interceptive canine vignettes, the 5th-year students are the ones that went to the schools, and the interns are the ones that unfortunately did not get to go to the schools. The canine vignette was a case scenario and 4 questions on it. And as you can see here, the percentage of people who got the right 3 correct questions from the 5th years was 50%, whereas just over 10% for the interns. The other vignette was about anterior crossbites, which was also a case scenario and 1 question. And as you can see here, almost 80% of 5th years who went to the schools got the question right, whereas, again, less than 10% of the interns knew the answers to the questions. Conclusion, school visits are effective in teaching clinical reasoning for interceptive cases. But then again, those interns that didn't know how to answer, what do we think? So I'm going now through the cycle again. And what I did this time was something new to me. And this was inspired by Dr. Sara Jabir, who was a fourth-year student at that time. And she said, why don't I do some snapshot clips and teach people how to do interceptive or how to manage interceptive orthodontics? And I said yes. So at that time, Snapchat had consecutive videos, which you do 10 seconds, and then you have to stop, and then you do 10 seconds again. We did that at Atwara clinics. Dr. Muhammad Al-Awfi very kindly let us do the filming in their clinics, and he also gave us a dental assistant. It was promoted beforehand by Nadia Ibtisama of the College of Dentistry, and it was filmed by my son. The total video time was 10 minutes, but it actually took about 90 minutes filming time because I really struggled doing the 10-second videos. And the only data that I could collect at that time was the number of people following, but then I did get some feedback later on afterwards. And these are some of the clips from the video, and this is Atwara clinics. And the patients were people that were actually friends and family that actually had interceptive cases. Well, so that's the students taken care of and the interns taken care of. Well, what about on a national level? Is this a problem only at Taiba University, or is it more on the national level? So this time I decided to do some classic research, and we did a cross-sectional study to see if it was a national problem. The authors of this study are Dr. Noura Dawiyan, Dr. Suha Sharif, Dr. Nada Dhubyani, Dr. Malaka Shamani, and myself. These are also graduated from the dentistry, and at that time they were in their final year of the dental school. So this was a cross-sectional study in which we distributed questionnaires. The questionnaires in themselves were a little bit different than the normal questionnaires. They had 8 scenarios of common interceptive orthodontic cases: retained deciduous, single tooth anterior crossbite, early loss of permanent tooth, increased overjet, digit sucking habits, up until severe anterior open bites. Now, each of these scenarios had 2 series of questions with them, some knowledge questions, which let us know how the students or how the actual recent graduate were good at diagnosis and management, but they also had confidence questions. So each questionnaire outputted 2 scores, a knowledge score from 0 to 1% and a confidence score, to 100%, and a confidence score from also 0 to 100%. For the knowledge, we put an arbitrary cutoff point at 50%, which meant that they knew how to manage the cases. The participants were dental graduates from the years 2015 to 2017. The inclusion criteria were graduates of government and dental schools in Saudi Arabia registered in the Saudi Commission for Health Specialties. So if they graduated from somewhere out of Saudi Arabia or they weren't registered, they were excluded from the study. The study sampling, we did a convenience sampling from seven areas of Saudi Arabia. We did want to do a different type of sampling. We wanted to take advantage of the database in the Saudi commissions for health specialties, but they didn't allow it. So we had to do convenience sampling, and we only managed to get 7 areas from Saudi Arabia, which was Medina, Mecca, Asir, Riyadh, Qasim, the Eastern Province, and Ha'il. We did descriptive analysis, and we did regression analysis, in which the dependent variable was knowledge, and the independent variables were age, gender, place of graduation, and confidence. The mean age of respondents was 25 years, so this is actually the expected age, so that was good. And we also had about the same number of male and female respondents, with the females being a little bit more in number. Okay, so for each scenario, we had a mean score. So for each scenario, we have a mean score. And if you look at the column where it says mean, The only score that actually reached the 50% was the scenario of the retained deciduous with no missing teeth. So we could say that that's the only scenario that the recent graduates really knew well. The lowest score was retained deciduous with no successor, so lots of people didn't know what to do with that. And then the only scenario that didn't get 100% maximum was the early loss of permanent teeth. So as you can see, the knowledge here for interceptive cases is pretty poor. We have a regression analysis for each of the 8 scenarios. I've not shown them here in the interest of time, but I do have the data if anybody is interested. The only one I put here is the one that had a significant effect. So there was a significant effect between the confidence of the doctors, all right, between the confidence of the doctors and between their knowledge, and that's really good because we don't want somebody to be confident of something and that they don't know. Conclusions: in general, dental graduates have poor knowledge of interceptive orthodontics, and perhaps exposure to a large number of cases may help in increasing this knowledge. Recommendations: orthodontic undergraduate curricula should provide more training on interceptive cases. So what now? Well, now I'm working with another group of students, but this time they're not students in the dental school, they're just students in the IT school. And we're looking into the use of technology in teaching interceptive orthodontics so that they can have more access to patients while they're learning. So if you're interested at all, follow me here at this space. And thank you very much for your attention.
Thank you, Dr. Safa, for your nice presentation. We'll postpone the questions to the end of the session. We have a time for discussion.
بسم الله والصلاة والسلام على رسول الله. الشكر الجزيل للجنة المنظمة على الدعوة الكريمة، وكرر الترحيب بالأساتذة والزملاء والحضور الكريم. Our second talk for this morning will be by Dr. Sari Burzanji. Dr. Sari is Vice Dean for Graduate Studies and Scientific Research and Chairman of Substitutive Dental Sciences Department at the College of Dentistry, طبي University. Dr. Sari obtained his Master of Science in Dentistry from School of Dentistry, Indiana University, United States. And he also obtained his Doctor of Medical Sciences degree from Harvard School of Dental Medicine at the United States. Dr. Sari will be talking about the use of guided dental implants in full mouth rehabilitation. Please welcome with me Dr. Sari.
Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee for allowing me to give this presentation to you today. And I'm honored to be here with you. The title of my presentation is The Use of Guided Dental Implants in Full Mouth Rehabilitations. Nowadays we have computer-guided implant surgeries where we use the computer and virtually we plan the implant in 3D models, and this can be with static guides or dynamic ones. The dynamic guides, while the doctor is drilling in the patient mouth, the computer will guide him to go right or left, up and down. However, the static ones, it's prefabricated and it's either being tooth supported or bone supported or mucosa supported. Research has approved that the teeth supported ones are the best to be used, and my presentation today I'll show you a case how we can use this technique to rehab a full mouth patient. So my patient, he's 58 years old. He said, I don't like how my teeth look like and I cannot chew. He's controlled hypertensive patient and he is on vitamins. When he came to us in the clinic, in our team, he couldn't smile. He doesn't want to smile. And when we enforced him to do that, we found this, collapse bite. So in addition to that, there is some pus coming out of his teeth. His dentist did composite filling to replace the missing teeth in the lower anterior area. If you look to his panoramic X-ray, as you can see, there's nothing of molars except one, so obviously he can't chew. The first thing we did, we put him back in correct vertical dimension and restore his bite with an interim. Then we used a computer program to place the implant in the right position where we want the future prosthesis to be done. Implant were placed with freehand technique, and then we start to work on the upper arch. We extract the teeth that causing the infection, and we prepared the other teeth to receive temporary prostheses. These are the temporary prostheses in. The upper teeth are retained by, the upper prostheses are retained by remaining teeth, and the lower prostheses are returned with implants. This is how it looks like from the sides, and you can notice in the back here we have to use additional acrylic with pink color to match the shade of the gingiva or the gums. And this is how the patient lived the day of the temporization. He couldn't smile. He can smile now finally. Then this is the use of the guide surgery, where you have to establish something called radiographic guide, as you can see it on the right picture. This guide will allow you, after you taking a CBCT, to use a digital software, and here I used Co-Diagnostic 9, where you can see exactly where are the implants will be. And if we look to the blue color here, this is the future implant. If we look to the green color, the two lines, these are where the sleeves will be, and this is how the final crown position will be. So before I touch the patient or do any surgery, everything is well planned. And my future work here in the research, I'm doing a controlled randomized clinical trial with the students to see the performance of the digital dentistry or digital workflow against the conventional one, and it seems that 94% up to now, they are convinced this is the right technique to go. These are the 4 implants we're going to place at the beginning, and this is how the implants will look like by the end of the surgery. This is the protocol which comes with the guide surgery and show you what are the right drills to use and what are the length and how you're going to cut it. So the patient came with the temporary on, and what we did during the surgery, this is a short video to show you how it works. So the sleeves here are used to cut the gingiva with water irrigation, and then these small pieces will come, and this technique will allow us to take off all the gingiva without opening a flap, and then you start drilling with the bone, within the bone, and water cooling must be done because avoid the necrosis of the bone. Then you go with the sequence. This is the blue drill with +3 handle according to the protocol. And then since we decide to use the red implants, then we have to go with the yellow one, and we follow that with the red drills. Then we're going to stabilize them here. Since this guide is attached with to the teeth, so these stabilizing pins, and then we're going to go and do the posterior ones as we did the anterior ones. So now you can see the holes, or where are the future place of the implants. Extra cooling must be used to avoid any heating of the bone, and we can use that with irrigation syringes. So, and this is the last implant in place or in preparation. Then the beauty of this guide, he will help the dentist to place the implant exactly as it was planned. And this is the implant. And then through the guide, through the drilling point, you just go ahead and place your implant in. And this is stabilizing an instrument, so the implant will not go deeper than it was planned. And this is the last implant in place. And this is the end after the surgery. We took the X-ray. You can see 4 implants in place, and the proximity of implant number 11 to the adjacent tooth was checked by taking a PA, and we found that there is good distance between them. Later on, we used an advanced technology which called ITERO, and this machine has a handle. This handle here, at the end of it, there is a camera where you can record the teeth without taking impressions. And this is how it looks like on the screen: the upper and lower arches and the bite of the patient. And this is the model. It was 3D printed, upper and lower, and the jaw relation on both sides. Then we had to add 2 more implants where the canines were, and we extracted the canines. We put now everything on implants, and this is after healing. And now we can see there is a gap between the provisional prosthesis and the gingiva, and this will be replaced by pink porcelain later on. And this is after healing after 1 week. Then we decided to place implants at side number 6 and 11. But here, when we opened the digital software, we found that there is some bone lost, and we have to augment these areas. So this is the planning. And then we went and we placed the 2 implants in place. However, if you can notice here, I had to open a flap and place some bone, and then we suture it. This is 2 weeks after healing, and this is 3 months after healing. Now the patient is ready to have his final prosthesis, and we used a pickup technique to attach the implants, the new implants, to the existing provisionals. Then we start to doing veneers on the lower anteriors, our lower canines, and doing the impressions for the lower implants. The final prosthesis, where you can see the multi-base abutments were used. And this is how the last, or the delivery of the final prosthesis. When we came to the upper arch, we noticed that we have to add pink porcelain, so I did again a final upper digital impression. And this is the method where I maintained my vertical dimension. I kept the temporary on one piece, and then I took the right side, and then I flipped the provisionals. And this is the final wax up, how it should be looked like in the patient mouth. I have to try it in. The wax up was placed in, we checked it, and then we transferred it to a metal framework where porcelain will be added, pink porcelain, and the selected color of teeth by patient was done, and this is how he looks like at the end. And this is the prosthesis. You can see the pink color, and you can see the lighter shade of upper teeth upon the patient request, since he doesn't show the lower teeth. And this is the final prosthesis using the guided implants where it was planned originally. This is the right side, and the left side in occlusion. And these are the implants in place. And this is how the patient looked like before rehabilitation. And this is how he looked like at the end. So this is a tooth transformation from having patient doesn't want to show his teeth to a beautiful smile. This is a quick and a glance on how the use of dental guided surgery and dentistry to do a full mouth rehabilitation. This can be done also on removable prostheses. With that, I would like to thank you all, and I hope I give you something you like.
Thank you very much, Dr. Sari, for this very interesting presentation. We will postpone any questions till the end of all 4 presentations in an open discussion.
السلام عليكم، صباح الخير. أشكر الدعوة الكريمة للجنة المنظمة على دعوتي للمؤتمر. May I introduce Dr. Jacob Talib, if I pronounce it right, Dr. Jacob. He's occupational therapist and associate professor of neurological rehabilitation, and he's specialized in very hot subject now. It is the use of robotic devices in rehabilitation. I'm a neurologist, and I knew how big it's, the neurological insult on a patient, because for one simple reason that brain doesn't have the regenerative power to produce another cells, and usually the disability is there. And this is one of the solution of that problem. So, Dr. Jacob, please, you may advance to the stage.
Thank you very much for the introduction. Welcome and good morning to the audience from my side as well. So first of all, when we take a look on the picture, you said it before, technology is coming more and more up in rehabilitation, especially neurologic rehabilitation, because we know a high number of repetition, for example, is very important to restore and regain abilities in patients. I must say sorry, first of all, because I ran a tiny mistake when I submitted my speech here, because today I don't want to talk about the effects of device-based overground gait training. I want to talk about a circuit class group training concept that we developed during the last years in Germany, especially in the neurologic rehabilitation. And we see it on the screen. So this is a picture how rehabilitation can look like in clinics today. And in many clinics, in up to 20 rehabilitation centers for neurology in Germany, rehabilitation of gait or of walking looks a bit like this. We see it more in detail later. Yeah. Okay, here are my disclosures and my conflicts of interest. So I think the most important thing is to say is that I'm sponsored by the Medica Medizintechnik, and all the other topics are not relevant for today. Yesterday was the World Stroke Day. So I want to focus today a little bit on stroke, also with the studies I want to show up and the research I want to show up. Don't be the one was the big message for this year. So prevention is more and more important when we talk about stroke, and but we cannot prevent all strokes, so sometimes we also must talk about rehabilitation. But maybe it's interesting also for you, how big is the risk that I suffer a stroke or that you suffer a stroke? And there is an interesting thing I found yesterday when I scrolled through LinkedIn and Facebook and all these social media channels. I found an app that helps us to identify our personal risk to suffer a stroke in the world. And we see it below in the picture, in the screenshot of the app, that the app makes a prognosis for a stroke of 5-year risk and 10-year risk. So maybe you can download it, and thank you very much. You can download it and check your personal stroke risk later. When we look on the Saudi Stroke Society, so I had a look on that on the internet, they have a clear strategic plan. So they want to develop in professional thinking in the field of stroke here in Saudi. They want to promote scientific proven and professional practice in stroke rehabilitation. They want to develop national stroke guidelines and registers that help us to understand stroke better. They want to facilitate the exchange of scientific and professional information inside the Kingdom of Saudi Arabia, and they want to outline the standards of practice for stroke management, and they want to maintain acceptable standards for stroke patient care. When we look in the world, then we must recognize that every 20 seconds a person in the world suffers a stroke. So we have more than 50 million stroke patients worldwide. And the big problem is we cannot prevent all these strokes, as we see here. And we have to know that every second stroke patient has a hemiparesis. So that means he's unable to move half of the body, sometimes left side, sometimes right side. And that leads to the point that 70% of all patients that suffered from a stroke rely on a wheelchair after 3 months of rehabilitation. And this is a big problem, because when we ask patients in the neurorehabilitation, what is your biggest goal, then we must understand that 90% of all the patients answer the question with, I want to be able to walk again. So walking as an increment of mobility is the most important factor for independent living, and it's also the most important predictor for independent living. So if a patient is unable to walk when he leaves the hospital or the rehabilitation center, then there is a big problem, because most of these patients are unable to have an independent living after that. So regaining walking ability is one of the most important goals. This is what we can summarize also here from studies made by Bohannon in 1991. And what we know when we try to understand neurorehabilitation, and when we try to understand the brain a little bit better, then we must see that it seems that there is a critical time window after a patient suffers a stroke, where plasticity in the brain is a bit higher than normal, and this helps us to achieve better outcomes. Okay, so an intensive training in the early phase and in the subacute phase of rehabilitation helps us to enhance the potential of neuroplasticity in a later phase, and so that helps us to get better outcomes. So we must start rehabilitation early. Here we see it again. So as a normal human, as a healthy human, we have normal brain plasticity, and after a stroke, we have a higher. We call it a hyperplasticity. So this hyperplasticity, we do not understand today exactly what happens in the brain and how all these mechanisms work. But we see in the result, in the outcome of the patient, when we start rehabilitation much as possible early, then that leads to better outcomes. And in the chronic stage, we see it here on the right side, the plasticity of the brain goes back on a normal level. So this is what I mean when I say we have a critical time window, and this critical time window is between 3 and 6 months. When we have a look in one of the biggest research ever done in physiotherapy or in physical therapy, then we must look on this paper from Verbeek. So it's the biggest review ever made in physiotherapy, and especially for stroke, It's combined with a meta-analysis, and it figures out, so more than 25,000 patients were included, more than 500 studies were included in this big review and in this meta-analysis. And the researchers tried to find out what are the effects, what is important for rehabilitation. And what they found out was, and what they figured out was, we have two aspects that are most important. And this is intensity of training, and this is task specificity. So what does that mean? That means that therapy, task-oriented intensive training and neurorehabilitation must be meaningful, it must be challenging, and must give fun to our patients. Our patients has to sweat, then training is intensive. It must be targeted to a specific functional goal that the patient has. And when the patient say to us, I want to be able to walk again, we should exactly train this, okay? That means task specificity. So we learn walking by walking. So it must be feasible, yeah, not too easy and not too difficult. So we must find the challenge point where we train our patient or treat our patients. And it must be a sufficient dose of intensity and must be graduated over time. So progression is also a very important aspect in rehabilitation. Sorry. Okay, now we come to the reality. So this is what we see here, what we have to do, but when we take a look to the reality, then we must recognize that our patients lay more than 60% of the day in bed. They are completely inactive and they are alone. They have no social interaction, and therapy is only a tiny, tiny part of the day where the patients are active. And when we dive a little bit deeper, more in detail, then we can see that also inside of one physiotherapy session, so this was measured here by Cower in English and Hillier in 2012, then we see that patients are only 64% in average active during a physiotherapy session. Okay, 60% of the day they do nothing, and when they have therapy, maybe 30 minutes or 45 minutes, then we must see that they are 1/3 of that time also inactive. So what went wrong in rehabilitation? We see it. 36% they are inactive, and we saw that task-specific training is much important. And when we see standing and walking practices, only 13 up to 15% of all the time. And a lot of other interventions are, let's say, they are a bit unspecific. The recommendation from international guidelines, so we know repetition, so the number of steps, for example, when we talk about walking is very important. And we look in the research and in the recommendations from international guidelines, so then we see that a patient that is unable to walk and is mobilized in the wheelchair after stroke should take 800 steps per day. 800 steps is the number of steps that a patient should take in the early stage of the rehabilitation to increase the chance that the patient is able to walk when he leaves the hospital. Okay? And we look here again on the reality, and then we see that in average patients only take 180 up to 200 steps. So this is not enough. And when we ask, so this is more a qualitative feedback now from the patients. When we ask our patients, is more therapy better for you? Many patients answer, for example, the more I did, the better it was, because this leg never worked and now it's working. And when we ask patients in the rehabilitation setting more training and intensity, what do you think about? One cannot have too much training, patients answer. And activity outside of therapy, the report of the patient is, the help was good downstairs, and downstairs meant here in the physio gym, but when I came up here in my room, I go to bed again, so what can I do? So patients often do not have an idea what they can do in their free daytime between therapies. And the question, are you bored and alone? Many patients answer, yes, I'm bored and I'm alone because here nothing happens, okay? It's boring, very boring. So now we come closer to the solution of the problem. I hope it's interesting for you. What we see here are a few pictures from a device-based circuit class training. It was a pilot project that we started in 2016 in 3 different neurorehabilitation centers in Germany. And we see a few pictures. For example, on the left side, let me introduce the pictures a little bit. A woman in an electromechanical gait trainer. It's an end effector gait trainer. The end effector gait trainer allows us to make a high number of repetitions, a high number of steps. So we have motor-driven foot plates, and the foot plates simulate a natural gait pattern for the patient. So the patient is harnessed here in the machine, is body unweighted, and can walk, and we can achieve 800 steps. So because we know that leads to better outcomes. In the upper right corner, we see another picture. We see treadmill training is also recommended in international guidelines for stroke rehabilitation. We see different balance tasks. For example, down we see again a patient on a treadmill trainer. Then in the middle of the 3 pictures below, we see a dynamic standing frame. So the dynamic standing frame enables us to bring the patient in a fall-safe environment. Many patients after stroke cannot stand sufficiently and alone. They need a lot of support. And to reduce also the stress and for the therapist, we can bring the patient here in a fall-safe environment and can train postural control and balance, what's also important for walking after stroke. All the interventions that we used here in this clinical setting are scientifically proven. So for all interventions we have today very robust evidence that this is helpful and this leads to good outcomes in rehabilitation. So for example, for walking, electromechanical assisted gait training is recommended in international guidelines. Also circuit class training is recommended. For walking endurance, circuit class training, electromechanical gait training and treadmill training is recommended. And for walking speed, especially a speed-dependent treadmill training is recommended, and a strength and endurance training. And for balance, here we follow again the task-specific approach. Balance can we improve when we make balance training, so we have to practice what we want to improve. We try to build up an algorithm that helps us to build boxes for the rehabilitation, because when we have 10 stroke patients, these 10 stroke patients are normally completely different. One of the patients is able to move the leg, another patient is unable, a third patient can walk a little bit, and the fourth patient maybe is completely immobilized and sitting in the wheelchair. So we have a high heterogeneity over the population of stroke and rehabilitation settings, and the question is, how can we target our therapy and a group therapy concept to the specific goal of each patient? Therefore, we designed a simple algorithm. So we built boxes and modules where we put task-specific interventions inside, and then we make an assessment at the beginning to categorize the patient in one of these boxes. And then we can start the training, and after 1 week, we recheck whether the therapy is efficient and effective or not. And if it's not effective, the patient stays in this box. If the patient improved his ability, then he went to the next box, okay? If we don't have any improvements after 4 weeks, then we have to think about maybe this therapy is wrong for the patient and we have to change the rehabilitation plan completely. 3 minutes, okay, now we are on the rush. Here we see the setting of devices, and we build two subgroups, one subgroup of patients that are completely unable to walk and one subgroup for patients that are able to walk. We have seen the interventions are slightly different between these subgroups, and now we come closer to the research we made over the last years. In the group setting, always 5 patients were supervised by 2 therapists, and we had a training time over 90 minutes. And here we see the outcome of the training time. So we see we could increase, or we were able to increase the active training time compared to that what we saw before from Hillier and English to up to 89% of active training time. So there's a significant difference between that what we have in the normal reality and what we have when patients make training and a circuit class training. And here with 34 patients in a cohort, we also measured the outcome and see that we have a significant better outcome or, from in the pre-post, in the FAC, so functional ambulation categories, and in the RMI, also in mobility index that we use in Germany for measuring the outcome of patients, especially for walking and mobility. And here we see the results of an RCT that we made in 2017. The yellow group is the intervention group that received conventional therapy in combination with standard physiotherapy. And on the right side, we see the group that only received conventional physiotherapy, and we see that both groups improved, but the intervention group in pre-post improved significantly better, and also in the when we look on the difference between the two groups, we see that we have a significant better outcome when we use the robotics in the therapy. The acceptance, and this is the last slide, I'm sorry that I'm a bit too late now. The acceptance of the devices, when we ask the patient, do you accept this training, is very high. They think it is helpful to regain walking ability, and they also think when we ask them that it's helpful to achieve patients' goals. Okay, conclusion. Device-based group circuit class training and neurorehabilitation is an appropriate and safe intervention to regain walking ability. It leads to a significant higher dose of therapy. This is very good because it's one of the most important things in rehabilitation. It improves the outcome of neurologic patients and should be established as a standard in rehabilitation settings worldwide, and maybe also here in Saudi. Thank you very much. If you have any questions, don't hesitate to contact me.
السلام عليكم ورحمة الله وبركاته. في البداية أحب أتوجه بالشكر الجزيل لإدارة المؤتمر لإتاحة الفرصة لي المشاركة في إدارة هذه الجلسة، وكذلك تشرفت بوجودي وسط زملائي الأعزاء في إدارة الجلسة ووسط حفلكم الكريم. Today, inshallah, I'm honored and pleased to introduce one of my eminent professors, Professor Dr. Adil Abdelhamid Nusir. Professor Adil is a professor of physical therapy for surgery and integumentary conditions. He is currently the Dean of the Faculty of Physical Therapy, October 6 University in Egypt. Also, Professor Adil has been entitled several academic posts in physical therapy faculties in Egypt, including being the former Dean of Delta University and also the former Dean, Vice Dean for Community Services and Environmental Development at the Faculty of Physical Therapy, Cairo University. Earlier, he was the chairman of Department of Physical Therapy for Surgery and Integumentary Conditions. Inshallah, Dr. Adil will introduce his lecture today entitled Physical Therapy with Stem Cell Transplantation, Fact or Fiction. But first, if you may allow me, dear colleagues and attendees, Dr. Adil would like to present an honorary gift to His Excellency Professor Abdullah Shinqiti, the Dean of the College of Rehabilitation Sciences at Taiba University and the chairman of the conference. Please, if you join us, Dr. Abdullah.
بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. إنها من دواعي سروري وعظيم شكري إن أنا موجود النهاردة بين زملائي وتلاميذي، والحقيقة أنا موجود في وسط مدينة سيدنا النبي اللي احنا كلنا بنعشقه وبنحبه. الحقيقة المدينة، أنا بشكر كل القائمين على هذا المؤتمر الدولي، مؤتمر المدينة الدولي الثالث، وبخص طبعا الشكر الهيد الكبير والأب الروحي لهذا المؤتمر الأستاذ الدكتور عبد الله الشنقيطي، عميد كلية التأهيل الطبي بالمدينة المنورة.
Thank you, Professor Abdullah.
الحقيقة ده الطب بتاع المثلث. اسمحوا لي ان احنا نجيب بقية اطلع المثلث اللجنة المنظمة. انا برحب اخويا وحبيبي الاستاذ الدكتور صلاح السيد. انا طبعا الدكتور صلاح والدكتور مصطفى هم دفعة واحدة، بس انا عشان راجل اكاديمي بقى بدأت بالصاد قبل الميم، فيعني في الكشف دايما بيبقى الصاد قبل الميم. ده ختامها مسك بقى. نكمل بقية المثلث. دكتور مصطفى صابر ابننا العزيز الغالي. هذا الإهداء الحقيقة من جامعة 6 أكتوبر، وإحنا بنشكر قادة جامعة 6 أكتوبر على إنها طبعا ما نسيتش اللجنة المنظمة، وإنها إن شاء الله بتفتح إيديها للتعاون، وإن شاء الله مزيد من التعاون. وشكرا جزيلا. السلام عليكم ورحمة الله.
Okay, Dr. Adil, if you may proceed, بإذن الله.
بسم الله الرحمن الرحيم، والصلاة والسلام على سيد الخلق أجمعين، سيدنا محمد النبي الكريم. أما بعد, today I'm going to present this very important point because physiotherapy is very important with hematological field or role of physical therapy in the hematological dysfunction or hematological disease or blood disease or blood cancer. The title of this topic is Exercise Therapy with Stem Cell Transplantation, Fact or Fiction. The purpose of this study to evaluate the therapeutic efficacy of the exercise approach to minimize the problem post-stem cell transplantation. When we look into the title and the purpose of the study, we will select some operational definition of term. Some definition, some operational definition, we will select from our title and our purpose. Number one, bone marrow. What we mean by bone marrow? Bone marrow, it is a spongy tissue inside some of bones, such as the hip and thigh, and it contains some immature cell. This some immature cell called stem cell. The stem cell development inside our bodies in 2-3 ways, in 2-3 forms. First cell is red blood cell, second cell is white blood cell, and third cell is platelet cell. And each cell has a special function. Bone marrow, as any organ or any tissue, if there any problem in the bone marrow, maybe the function will be disturbed and will be damaged in different systems of the body. But the new techniques to correct this damage or this problem is the transplant technique. What mean by bone marrow transplantation? Bone marrow transplantation, we will change or transfer a healthy or damaged cell of bone marrow to normal bone marrow. We will change the damage or abnormal bone marrow cell to healthy cell to correct the problem and to restore the maximum function of the bone marrow. Bone marrow transplantation has been treatment choice and good model treatment for patients with very different patients with hematological disease, and these techniques will provide a good clinical and health results. Common indication of stem cell transplantation: leukemia or aplastic anemia. What do you mean by leukemia and what do you mean by aplastic anemia? Leukemia means abnormal maturation or formation and unregulation production and formation of leukocytes or normal blood cell. But aplastic anemia means bone marrow contain a very few blood cells. Bone marrow or stem cell transplantation divided or classified into two main techniques. First one means allo bone marrow techniques, and the second one is auto bone marrow techniques. What do you mean by allo bone marrow techniques? It is a techniques that receive blood from donor bone marrow. Donor bone marrow. Donor bone marrow, what I mean, what from other person. We receive healthy blood from other person. This technique called allo technique bone marrow. And but the second one is auto technique. Auto technique bone marrow transplant. It means that involve or receiving a healthy blood from the same blood cell in the same person. This figure shows the donor or allo technique. Allo technique, I receive a normal or healthy blood from other person and reject to the affected or patient. This second figure shows the auto technique. When you show the auto techniques performed in 5 steps. Number 1, bone marrow removed or blood is drawn from the same person. And this blood is collected and slide on chemotherapy and freezing, put in freeze. And after that, after freezing and chemotherapy application, stem cell returned after cleaning it from the diseased part, from the cancer or other abnormal cells, and reach to the normal tissue, and after that, stem cell will return to the bloodstream. This technique is called auto techniques. From the same person, I reject, I withdraw blood, and after that, I'll clean it. And the third techniques, I put it in the body again. Our topics today, the effect of exercise and the stem cell transplantation or bone marrow transplantation. Exercise as chest physical therapy, as aerobic exercise, as walking re-education, underwater walking re-education, circulatory exercise, respiratory exercise, early ambulation, application of positioning. There is a lot of exercise, a kind of exercise will performed with stem cell transplantation. The patient evaluation, we can evaluate the patient in different categories. Number one, balance assessment, endurance assessment, coordination assessment, postural assessment, muscle performance assessment, range of motion assessment, and daily living assessment, and walking, abnormal walking assessment. After renal transplantation, we have a lot of problems. Number one, increase risk of respiratory complication. Number two, increase risk of circulatory complication. Number three, we have abnormal pattern. Number four, we have a lot of fatigue. We have severe weakness of muscle. We have very limited of joint. We have coordination is unbalanced. We have a lot of this problem. This problem transfer to different aims. What are the main program of treatment that deal with this patient? Number one, life-saving program. Life-saving program means circulatory exercise and respiratory exercise. Circulatory exercise subdivided into different pattern, unilateral pattern, alternative pattern, bilateral pattern, and the form of circulatory exercise are classified into ankle pumping exercise, figure of 8 exercise, ankle rotational or ankle circle exercise, dorsiflexion and plantar flexion. But the respiratory exercise include diaphragmatic breathing exercise, segmental or localized breathing exercise, exercise associated with breathing, exercise in upper extremity associated with breathing, exercise or lower extremity associated with breathing, incentive spirometry exercise. This figure shows a form of respiratory exercise. Inhale, exhale, for counting exercise, inspiratory exercise, resisted breathing exercise around 2 inches above the diaphragm to resist the movement of the diaphragm, because the diaphragm, weakness of the diaphragm, one of the main cause of muscle weakness. Circulatory exercise, dorsiflexion, plantar flexion, fist grip, circular exercise, number 2, cardiovascular or aerobic exercise, walking training, bicycling, treadmill training. All these form of exercise or cardiovascular exercise, the value are to improve the body ability to use oxygen, to decrease the heart rate, and improve blood pressure, to improve heart rate and lung. This figure shows the walking training, bicycling training, underwater exercise, walking underwater, parallel walking, bicycling, treadmill. Third form, we can use some form of exercise in some different of a starting position, like prone lying position. I can perform some specific exercise. In a standing position, I can perform some specific exercise, and sideline, sitting, quadruped, supine. This figure shows exercise for patient after stem cell transplantation with different starting position exercise. Supine, when puts a patient in supine, what types of exercise you can perform? Like manual assisted exercise of upper and lower extremity, and so on, as goes with table. Exercise is very important to minimize complication and the problem with stem cell transplantation. What is the scientific explanation? What are the research that based on this exercise is very important? Scientific explanation focused on three main concepts. The scientific explanation around three concepts. First concept, exercise and muscle performance, exercise and the immune system, exercise and fatigue. A lot of research and studies go to around these main concepts. First concept, exercise and muscle performance. This concept found that exercise intervention improve muscle performance through, number one, increase muscle power, number two, improve range of motion, number three, it is very important to convert, to accelerate a nutritional support between protein and the muscle mass. There is a ratio between protein and muscle when I perform muscle contraction to minimize fatigue. Protein go to the muscle to interact, to balance, to maintain the balance between a nutritional support of protein and the muscle contraction. Second concept.
3 minutes, please.
Yes. Second concept, exercise, protect and enhance the immune system through exercise or muscle contraction, increase resistance to infection, and enhance the immune response. Details and the explanation about this second concept, exercise boosting circulation through increase in number of neutrophils and the monocytes, improve in natural killer cells through plasma adrenaline account, modulation of natural killer cell function. وده موضوع مهم جدا ان الناتشرال كيلر خلايا الاكاله او اللي عايزه تاكل اذا زادت عن حدها بقت مشكله كبيره. ممكن تاكل من الهيلثي تيشو. ربنا خلق لها بالانس باعجاز غريب، الميديوليشن اوف ناتشرال كيلر سيل اللي بيلعب دور كبير بين البالانس اند ادرينالين اكاونت. Third concept, there is a linear relationship between the application and the manifestation of fatigue. Muscle contraction will reduce the application of fatigue through change in muscle mass and plasma volume, improve lung ventilation, increase concentration of oxidative muscle enzyme. All of these increase the endurance and resist the fatigue. Conclusion, therapeutic exercise, very effective, has a positive effect on minimize the fatigue, to improve the muscle power, to maintain a normal pattern of walking, to improve the range of motion, to improve the respiratory system and prevent respiratory complication, to improve the blood vessels, we minimize respiratory complication. All of this will reduce severity and side effect of transplant and reduce the fatigue and improve quality of life. وأنا هنهي كلامي إن العلاج الطبيعي أو life is movement. دكتور حمدي مرسي بدأ بالموف، أنا بقول إن الحياة هي movement. life is movement. طبعا دكتور الأورام وزرع النخاع بيعمل التكنيك عالي جدا، بدون العلاج الطبيعي هذا التكنيك يفشل ويرجع يرد تاني، الخلايا السرطانية ترجع ترد تاني بالشغل بعد ما حولت أنا الخلايا السرطانية إلى خلايا سليمة. إذا ما خدش موفمنت وإكسرسايز بقت مشكلة كبيرة جدا، وممكن يرجع يرد تاني زي ما قال الدكتور أحمد الشنقيطي امبارح، وزي قال محاضرين كتير الحقيقة قالوا إن التكنيكس ميديكال أو سيرجيكال لا يكتمل إلا بالهرم الثالث. وأنا بقول 3 أهرامات في القطاع الطبي: هرم الطبي الأدوية، ثم الجراحة، ثم العلاج الطبيعي. وأنا شكرا جزيلا لحسن الاستماع، وبقول إن العلاج الطبيعي له أدوار كبيرة جدا، وعندنا بحث بنتعمل قدامه 1.5 سنة ويخلص. جبنا كل الإكسرسايز دي حطيناها في صورة بروتوكول. أول يوم هنعمل إيه، تاني يوم هنعمل إيه، تاني أسبوع هنعمل إيه، لمدة 4 شهور. ده الحقيقة البحث ده هيكمل كمان 1.5 سنة. بس لابد إن أنا قبل ما أنهي المحاضرة إن أنا أشكر معالي الأستاذ الدكتور حسام كامل رئيس جامعة القاهرة الأسبق، لأن هو أستاذ زرع أورام وأنا كنت عميد. كان دايما يقول لي إيه يا دكتور عادل، دور العلاج الطبيعي هام جدا في زراعة الأورام وزراعة الأعضاء. أنا طبعا ساعتها الموضوع ده احنا بدأنا فيه من 3 سنين، بس كان بالنسبة لي موضوع جديد جدا. ستيم سيل ترانسبلانتيشن دخل مصر من 3 سنين بس، عندنا 8 رسائل ماجستير و2 دكتوراه وورقة علمية هتظهر كمان 1.5 سنة إن شاء الله. شكرا جزيلا. شكرا.
Assalamu alaikum. I am delighted to invite our speakers for this morning session to the stage. Would you please come, please? We have 10 minutes for questions, please. If you have any question to our speaker for this morning.
Good morning. My question, Dr. Jacob. Here, Dr. Jacob. You should. Again.
Yeah, I think your question was whether I have personal experience with rehabilitation of children in neurologic rehabilitation. Personal me not, But we have also centers in Germany that work with our devices. So, for example, the gait trainer Lyra can also be used in children rehabilitation and other devices as well. So it's also common to use it because there is no big difference. So it's also a human, it's only a bit tinier than me. But my personal experience is very, very light.
Thank you, Dr. Ismail.
You know, for the or the orthodox, way of transplantation and what you did show us today, if there's a big difference in the cost.
Okay, thank you for your question. Regarding the cost, yes, it will be additional cost, of course, for using the machine, preparing the guides, even the implant itself, it's going to cost extra, for sure. Regular implants usually cheaper than this. You have to pay for the lab technician, and you have to pay for the technical support from the company who will assist during the implant designing in the software. And also you have to pay extra fees for the guides. The more guide you use, the more implants in the guide, the higher the cost will be.
Yeah, but if there's, with the usual, what would be used now for implantation, usual way of الزرع يعني اللي بيصير هذه الأيام. هل في because you use a lot of devices and it's much more accurate. It seems that it's all of it is computerized, but what I know now about now is just most of it manual. What we are seeing right now, it's not computerized.
Okay, so this is the digital workflow. It's something new in dentistry in general. However, about accuracy, yes, there is better accuracy with the guided system. But when we talk about digital impressions or digital treatment planning, you can achieve the same results with the conventional methods. However, experience of the surgeon or the technician will play an important role to overcome the accuracy of the digital flow.
Thank you, Dr. Sari. Please.
My question, is that for me or for?
I'm Dr. Faisal Bagmi, Imam Abdurrahman Faisal University, and my question to Dr. Jacob about rehabilitation robotics. I'm also interested in rehabilitation robotics, and I have a presentation on it later on. We just have, one of the things you mentioned in the gym, in the robotic gym, is we have to be the algorithm. And one of the things, the algorithm does simulate the exercise, but there's a lot of debate around these algorithms and the evidence behind it to do with the exercise. That's one. Second thing, we still see that the rehabilitation robotics gym that is going on, they are considered a middle step between the two, because the main goal is for the patient to have this robotic prosthesis, whether it's exoskeleton or whatever, to be incorporated in the daily life of the patient. So what are your views on that?
Sorry, what?
What are your views on that? It's because everybody's pushing the rehabilitative gym, robotic gyms, but I see them as there's a lot of evidence, scientific evidence that there's inconsistency in them, and the model is 2 to 5, so they still incorporate a lot of cost for them. So what do you see the direction going for?
Yeah, thank you for this question. So multiple questions. I try to answer it as shortly as I can. So on the one hand, yes, you say an important thing. So robotics are expensive, and we have to invest in it. And we have to use it very efficiently in the rehabilitation. I think this is one of the big issues that we have, for example, in Germany. So we can observe that in the past, many of the hospitals and the clinics, they invested in robotics to use it in the rehabilitation setting, but it was not efficient in the end because they had the devices, sometimes they used it, sometimes not. So I think the important thing to make it run a concept like this is to have a clear structure and a clear plan what you want to do. And that's why we developed this algorithm. So we looked in the literature, we looked in the international guidelines and tried to figure out and find out what are the best ways to treat patients on the machines in a specific stage of the rehabilitation. And then we said to the therapist, okay, how can we bring it into practice? So it's a knowledge to action process that you must go together with the therapist. You must motivate the therapist. Often therapists also think that robots will do the therapy better in future than they do it by themselves. And this is completely stupid. A device like this is completely stupid. It cannot do, it's only a support machine for the therapist. And I hope that you don't get me wrong when I show up a concept like this, because you need a therapist. You need a therapist. You need the expertise of the therapist, and also for the assessments, and also to decide in which box, in which module I put the patient in. This must be a decision made by a physiotherapist, an experienced therapist. Otherwise, it's not possible. So it's not an algorithm like a computer say, you must do this and you must do that. It will never work, okay? Yeah.
Thank you. We'll take a question from female side, please. If you...
السلام عليكم. سؤالي للدكتور عادل. دكتور يعطيك العافية على المحاضرة. أنا فقط أبغى أسأل. I want just to ask if you have any efforts, research effort to develop policies using exercise as a prevention, protocols to prevent breast cancer, protocols to prevent bone cancer, protocols to prevent ovarian cancer, the cancers that kill every lady in the, a huge number of percentage in the Middle East, mainly the breast cancer, since we are in October right now. The percentage is increasing. Actually, science is not helping to prevent it. Maybe, hopefully, that exercise will help in that. Do you have any future plans to make some policies targeting specifically each type of cancer alone? I know that there are general exercise rules, but I mean specific ones. I think we need that, and if there is any plan for that, it will be an amazing, and hopefully it will be a plan designed for Middle East ladies or Middle East population, because I think we have our own private issues, economical, environmental, genetical. We are special in many ways. I think we need something for us. Thank you.
شكرا يا فندم، شكرا. الحقيقة احنا بالنسبة لأور فيوتشر بلان احنا بنخطط في اتجاهين بالتعاون مع معهد الأورام جامعة القاهرة. الحقيقة معهد الأورام عنده مكانين سبيشال سنتر على مستوى العالم، معهد ناصر ومستشفى الشيخ زايد التخصصي. الاثنين بيعملوا فيهم ترانسبلانتيشن. احنا بنعمل الاكسرسايز في خطين. انت عارفه حضرتك لما ندرس العلاج الطبيعي، معلش انا اسف بتكلم بالعربي، العلاج الطبيعي من ضمن اهدافه على مستوى العالم American Association of Physical Therapy، اول هدف لينا بريفنشن، ثاني هدف لينا ثيرابيوتيك. فانا لازم استخدم الهدف الاولاني. احنا بنعمل عن طريق تحليل الدم نيتشر كيلر سيل ان احنا بندي ووكينج ده مهم جدا، ريجولار ووكينج للميل اند فيميل. احنا ماشيين في مشروع دلوقتي، لان زي ما حضرتك تفضلتي قلتي عندنا بريست كانسر في مصر بالذات الريت بتاعه بتاع حدوث المرض عالي جدا. فاحنا بندي اولا عن طريق ناخد عينات عشوائيه، عن طريق التحليل كيلر سيل، بعرف ممكن في المستقبل، طبعا المستقبل ده في يد الله، ان ممكن يجي لها سرطان بعد 2 3 ضمن التحاليل ضمن بروتوكول. فبندي بروتوكول مشي وبدكتور اكتيفيتي، لان خدي بال حضرتك الاكتيفيتي دايما لما تقري في الكلام ده، الاكتيفيتي اجينست السرطان. السرطان ليه بريدسبو او لغايه دلوقتي انون كوز. السرطان بيجي نتيجه مفيش موفمنت. عشان كده الامبريلا بتاعتي بقول لايف از موفمنت، وزاويه موفمنت بقت في مشكله على مستوى الادلت، على مستوى الاولد ايج، على مستوى التشيلدرن. لقينا الناس اللي عندهم فيري اكتف تلاقي ربنا حميه من حدوث السرطان. هقول لك حاجه اخطر من كده، عملناها دراسه ميدانيه في الستينيات في جمهوريه مصر العربيه. كان بعض السيدات بتخاف لما تخلف، تخاف تعمل نورمال لاكتيشن. فيحصل ايه؟ ربنا خلق البريست هنا عشان يؤدي وظيفه معينه، هو خلق كده. فانا خايفه على القوام بتاعي كسيده، فتقول لا انا هديله درايد ميلك. يوم ربنا يقول لها كده، طب انا هشيل النورمال اورجان ده. لقينا نسبه كبيره من السيدات اللي جالهم بريست كانسر ما بيعملوش رضاعه طبيعيه، ودي مشكله كبيره. مش ما بيلاقوش، لان في عندنا بعض الحالات المرضيه ما بتقدرش ترضع رضاعه طبيعيه، وبالتالي ممكن تاخد الريبليسمنت بتاعه درايد ميلك، ولكن هي طبيعيه جدا، ولكن خايفه على القوام بتاعها. فلقينا قرار جاي، قرار الهي. فعشان كده الاكتف، عشان كده تبص حاجه البروفلاكتنج، احنا دايما العباده فيها حركه. كان قادر رب العزه يقول لنا والله وانت بتصلي كده بعينيك ما تتحركش، انما ده ادانا موفمنت. وسيدنا رسول الله قال له اخوك اللي بيشتغل احسن منك، انت قاعد في الجامع عامل، ما فيش رهبنه في الاسلام. قال له انت تشتغل وتعمل موفمنت. انا بقول مور موفمنت ووكينج بالذات. عاملين برضو بالاتفاق مع دكتور ابراهيم ان احنا هنعمل ان شاء الله في كليه علاج طبيعي اكتوبر، ان احنا هنعمل فوائد المشي للديفرنت ايج. هنجيب ديفرنت ايج ونشوف فوائد المشي ده مهم جدا. بروفلاكتنج كتير ده طريق، يبقى انا بعمل طريق الاول، بحاول اقلل حدوث الاصابه، لان الاصابه دي في يد الله. طب وانس حصلت الاصابه هعمل ايه؟ انا ما بتعالجش مع، خدي بال حضرتك، انا ما بتعالجش مع السرطان دايركت، ده بتعالج معاه بعد ما الخلايا السرطانيه دي تتحول الى نورمال اور هيلثي سيل، بعد ما اتعمل ترانسبلانتيشن عن طريق الاوتو تكنيك او الاولو تكنيك. بالطريقتين دول انا بحول الخليه من خليه مرضيه الى خليه طبيعيه صحيه. بس لو ما استمرتش على الموفمنت بقت مشكله كبيره، زي ما قال الدكتور الشنقيطي وقال بعض الناس كتيره امبارح، ان الجراحه والطب هايلين فوق دماغنا، بس الريهابيليتيشن مهم جدا. ترانسبلانتيشن وزاويه ريهابيليتيشن، العمليه فشلت وتحولت الخلايا السرطانيه اللي بقت ترجع تاني بطيئه، مفيش فيها حركه، اتحولت الى خلايا ابنورمال تاني. يبقى انا خسرت ايكونوميك، خسرت عيان بيصرف لي فلوس، لان العمليه دي مكلفه. الستيم سيل ترانسبلانتيشن دي مكلفه جدا. اعتقد ان انا وصلت الى محور سؤالك، اتمنى يعني. واحنا ماشيين في الساينتفك وورك، وان شاء الله ربنا يهدينا، لان كل عمل احنا بنعمله لوجه الله لازم ربنا هيوفقنا ليه ان شاء الله. شكرا يا فندم.
Okay, thank you, bro. Last question, please.
Okay, my name is Dr. Okay, here. Dr. Adil. I am asking Dr. Adil. Prof. Adil. So I am Dr. Badr Hamza. I am a consultant rheumatologist. My question, Prof. Adil. So regarding the stem cell in patient with I attended the meeting. They show cerebral palsy cases and they inject the stem cell in the CSF fluid. It shows within months significant improvement. Any idea to try this?
واستخداماته، بس احنا يمكن عشان قسم العلاج الطبيعي للجراحه ان انا اتطرق قوي للسي بي، بس معظم دكاتره ستيم سيل ترانسبلانتيشن اللي هم بيزرع للسي بي، ويزرع الحالات الهيموبليجيا، ويزرع الحالات كتير قوي. بس احنا عشان اسم الجراحه له علاقه بالسرطانيات، فعملنا الستيم سيل ايمنج. الهدف بتاعي المريض هنا هو المريض السرطاني، واخد بالك. انما طبعا شفت حالات كتير بس احنا ما اشتغلناش عليها، حالات سي بي وحالات كوادريبليجيا وحالات هيموليجيا، بس انا لا اعرف نتائجها. انما اللي اعرف نتائجه اللي انا قلت لحضرتك عليه، اللي هو الهيماتولوجيكال البلاد لما يحصل فيه كانسر يبتدي ياخد البلاد، يسحب البلاد الكانسر البلاد ويحطه تحت كيموثيرابي، يبتدي يطهره وبعد كده يحفظه في فريزنج، وبعدين ياخده بعد ما يتحول الى خلايا طبيعيه ياخده يحقنه تاني في الجسم تاني يرجع نورمال تاني يؤدي وظيفته، بس محتاج الحركه. اما التكنيكس ستيم سيل مع السباينال كورد او مع السي بي او مع حالات ليفر ديسفانكشن كمان بيعملوا ستيم سيل ترانسبلانتيشن، بس احنا ما نعرفش عنها حاجه. يعني أنا الاسم بتاعنا ليه تيتشنج اند educational emphasis، ما بقدرش انا اتعداها. يمكن عندنا اسم النورولوجي يقدر يشوف الجزء ده، او اسم البيدياتريكس لو احنا واخدين السي بي واخدين الهيميبليجيا والكلام ده. بس نفسنا طبعا تبقى ابحاث كلها مشتركه تصب في صميم العلم. شكرا.
I'd like to ask a question before I leave. Is that okay? That's for Dr. Safa. Thank you for your presentation. It was very, very important to the educators for physical therapy. You have presented two ways of acquiring clinical skills. So acquiring the clinical skills, is that better to have it in Vignata and giving a case study for the students to analyze and to come up to the clinical decision, or to actually see the patients? What the difference between like seeing the patient themselves or giving them case study, written case study to analyze?
Okay, thank you very much. I think it's better to see patients, but this is the problem. This is the problem behind all of the research, is that on clinic, we don't always have access to a large number of patients that we can see that are suitable. It's not the clinical skills that I was looking after, it's the clinical reasoning skills, which is diagnosis and planning. We don't have a lot of problems with the psychomotor skills. It's actually the clinical reasoning skills. And yes, you need to see lots of patients in order to actually do that, and that's the problem. When you go on clinic, when we are teaching, we don't have enough patients for the students to see, so therefore there's always a gap, and when they graduate, that gap never fills in. What I'm doing now is something that might help. I'm looking into simulation using technology so that there's always access at any time to simulated patients through technology. We haven't chosen the technology yet. And I think that when you have more access and when you have more cases to see and different types of cases to see, I think then the learning and the clinical reasoning will improve a lot. Thank you very much for your question.
Thank you, Dr. Safa. We should close our session now, and I want to express my thanks to our speakers for this morning and my colleagues, chairpersons. Would you please come to the stage, Dr. Ismail, Dr. Hani, and Dr. Shawqi? Would like to present on behalf of the organizing committee and the scientific committee, would like to present honor shield for Dr. Sari Burzanji.
دكتورة صفاء. دكتور عادل نصير. دكتور جاكوب. في هدية مقدمة من مؤسسة هدية تعالم للدكتور جاكوب. صف. ان شاء الله كافي بريك 15 minutes ونرجع تاني بسرعه. الله يكرمكم. كافي بريك 15 minutes. ها ان شاء الله تعالى.
السلام عليكم ورحمة الله وبركاته. نبدأ إن شاء الله السيشن الثاني الصباحي، فأهلا وسهلا بكم. نرحب بالدكتور أسامة عبد العال. أتمنى أنه يشرفنا على القاعة. الدكتور أسامة طبعا هو Assistant Professor Diagnostic Radiology and Technology Department في Applied Medical Science College. He held the PhD والMS والماستر from the School of Medicine in Dublin, and he has a training experience in clinical radiology and MRI at King Abdulaziz Medical City National Guard and King Fahd Hospital and Bonscourse Hospital, Dublin, Ireland. He will talk today about the 3D magnetic resonance imaging of the knee joint. Welcome with me, Dr. Osama Abdul Al.
Bismillah ar-Rahman ar-Rahim. Thank you for introducing me. It's an honor for me to present today with you guys. As we know that knee abnormalities can lead to disabilities, and we usually use MRI to evaluate and monitor the pathological changes within the knee joint. So today I'm going to talk about two different techniques for evaluating the knee joint using MRI 2D and 3D. So what is MRI? Sir Peter Mansfield, who is a Nobel Prize holder, reported that it is a different type of image that carries with it much more information about the disease process. Knee imaging has undergone considerable advances over the past 2 decades, which have revolutionized practice and radiological diagnosis for identification of both normal anatomical structure and pathological changes. Delineating fine detail of the knee joint is challenging because of the nature composite anatomy of oriented and small structure size. Disorders of the knee joint is a significant source of patient referrals, placing pressure on imaging resources. It is essential to provide the referring clinician with an accurate characterization of any abnormal features present within the knee joint to guide optimal treatment and patient outcome. CT is considered as a valuable imaging modality for evaluating the knee joint. However, it has some limitations, such as, for sure, the harmful ionizing radiation, the invasiveness associated with the intra-articular injection of contrast material typically required to increase the contrast between cartilage, joint fluid, and adjacent anatomical structures. Knee cartilage defect can be evaluated by CT scan with a sensitivity of 80% and specificity of 88% using multi-detector spiral computed tomography. Literature has reported that MRI is considered the gold standard technique for evaluating the knee joint, for evaluating and monitoring the knee joint. MRI is superior to CT scan because of its higher soft tissue contrast, multiplanar capability, and for sure, the lack of ionizing radiation. Knee imaging can be evaluating, as I mentioned before, using 2D or 3D techniques. Before I proceed to the deeper, I would like to talk about briefly about when I say image weight, especially for students who have limited knowledge about MRI. So what is the difference between MRI and X-ray, for example? In X-ray, the bone usually is bright, hyper intense, soft tissue is gray, and air is black. But in MRI, we have different story. In MRI, we have different weights. It's like we have different imaging modalities in a single scanner. So for example, here, if you can see here, this is called T1 weighted image, while here it's T2 weighted image, both for the brain, but why we have the CSF, the cerebral spinal fluid is bright here, while it's dark here. So it's all about the hydrogen protons. We take the energy or the signal from the hydrogen protons within the human body. Let's say it's dark here, the white matter, the brain consists of mainly of white matter and gray matter. So if we can see here, the white matter here is hypointense because it's mainly 70% of it is lipid, mainly fat, while the gray matter and the CSF mainly water. So that's why reduced water and unique lipid content of white matter results in having shorter T1 and T2 relaxation time. So these terms are quite technical, so I don't want to go deeper, but I would like to explain why we have different weights. Usually we use like T2 to evaluate pathological changes, while T1 to evaluate the anatomical structures and post-contrast. Gray matter appears hyperintense in T2, and CSF hyperintense as well because the high level of water within these anatomical tissues. We have different types of image weights. So we have T1, T2, flare, stare, gradient, trophosp. So each image weight is for specific disease. So for example here, we have a patient with MS lesions in the brain. We use T2, which is usually the perfect sequence to evaluate pathological changes, but here we use flare. We use the flare because we suppress the signal from the fluid, the CSF, so we increase the contrast so we can see the abnormal lesions here. And not only the weight of the image, we also use different planes. So here we used axial images, and here we used sagittal image. And that's why this is the perfect image weight and plane to evaluate MS lesions. So as I said, we have axial, coronal, and sagittal planes for the MRI. Usually, any MRI protocol, we have different sequences. Now we have coronal. For when you evaluate the knee joint, we have coronal stare, for example, and we have 2 minutes. Sagittal proton density, this is the plane, and this is the weight of the image. And we end up with around 14 minutes to evaluate the knee joint using 3 Tesla MRI scanner. So now, if we go back to the knee joint, we can see that we use T1 and T2 to evaluate abnormality here. So T1 weighted image are used to evaluate anatomical structure but have poor clinical performance with a sensitivity of 85% and specificity of 97%. While T2 image are superior to T1 images when evaluating pathological changes with a sensitivity of 94% and specificity of 99%. And we can clearly see the abnormality over here. And this technique failed to catch the abnormality. So the conventional 2D is the excuse me, the gold standard method for evaluating knee joint, different planes with different weights, excellent image quality, and short acquisition time, less number of images, even for radiographers and radiologists. Less time for radiographer, no need to construct images, and less time for radiologists to read. 2D images, usually we use 25 slices or images, while 3D we usually use 200 or 150 images based on the slide thickness we used. So I'm going to talk specifically about the slide thickness and gaps, partial volume averaging artifact, and spatial resolution and SNR between 3D and 2D images. So first of all, slide thickness and gap. 2D sequences have gaps approximately 0.3 millimeters between slices. Why we need gaps? So this is the 2D, and here the 3D sequences. So here, for the 2D, we have a slice 1 and slice 2, or image 1, image 2. Why we have gaps here? So if we have an abnormality here with 2D images, we might miss the abnormality or some of the abnormality. So why we have to have gaps between slices here? Because in 2D images we excite each slice separately. We send energy, RF excitation pulse or radio waves to this slice. Then we collect the signal from this slice. Then we send another RF or energy to the next slice to get the information from. We need to leave gaps here because some of the energy might leak to the next slice. We end up with an artifact, could affect the diagnostic performance. While 3D images, we excite the whole volume of the knee joint. So not one slice or two, the whole volume. So let's say 200 images we excited all together, then we construct the images. So if we have an abnormality here with the 3D images, we have no gaps and continuous slices. So we will be able to investigate, or we will be able to evaluate and monitor subtle, small abnormalities. 2D technique produce images with thick slice thickness around 3 millimeters than 3D images which use around 0.5 millimeter. Small areas of pathology can be mimicked or obscured by partial volume averaging artifact. MR signal is averaged and not accurately represent each tissue type within a given voxel. Let's pretend this is the MR image, and we have within that image so many voxels. So if we have this voxel here, if we have a thick slice thickness, we have the abnormality and healthy tissue, we might end up with signal intensity from both the normal and the abnormal tissues. So the typical appearance of partial volume averaging artifact is a combination of different intensities generated from different tissues. And we can see here, if we have a voxel, we have different signal intensities from normal and abnormal anatomical structures. And this could lead to display, the signal intensity of the displayed pixel will represent an average such that signal of the pathology might be changed or mimicked. Here a clinical example, it's about what I was talking about. So we have the 2D here and we have 3D images here. So in the 2D images, only one image was able to detect the abnormality with average signal intensity from both the normal and abnormal tissues. While the 3D sequences successfully detected the abnormality with high spatial resolution and contrast as well. So we can see, we are able to see the abnormality here compared with the 2D sequences. Spatial resolution, I'm going to talk about, could be affected by field of view, matrix size, and slice thickness. I'm going to go directly to the slice thickness. If we have thick slice thickness, we decrease the contrast, spatial contrast, and we increase the SNR. We have an example here. So this is the 2D and this is the 3D. 2D is thick slice thickness, 3 millimeters, and this 1 millimeter, thin slice thickness with 1 millimeter. And we can see here, this is the slice thickness with 3 millimeters. It contains more information, more SNR, but the spatial resolution is quite poor. Compared with this one, has lower SNR, but higher spatial resolution. And in this image, we are able to see fine details. So the thinner the slice, the greater the ability to resolve small structures, reducing the slice thickness, therefore increasing spatial resolution. And we can see here, let's pretend this is a high resolution image, and this is the standard resolution. This image is quite pixelated, while this one it's sharp, and we can see subtle abnormalities. So the higher spatial resolution can lead to improvement in the visualization of fine structures. In clinical practice, it is important to achieve balance between scan time and image quality. 3D could be useful technique for evaluating oblique or small structures within the knee joint, like cartilage defects and meniscal root tears. Here is a nice example about high spatial resolution and spatial resolution images. If we look at these two images here, it's fine. This image have so many informations, and this one, the standard resolution is fine. But if you are looking for fine details or fine or small anatomical structures or even abnormalities, this one, the high spatial resolution, provide more information for subtle abnormalities or normal anatomical structure, while this one is quite pixelated, and if there is abnormality, we can't really see it. 3D imaging has many potential applications, especially for joint. The use of 3D sequences for evaluating the knee joint could replace the conventional 2D sequences.
Dr. Sama,
yes?
3 minutes more.
Okay. So 3D sequences provide thin slice thickness and continuous slices, and that allows for comprehensive coverage and avoid partial volume averaging artifact. If we have the 3D image, we have the raw data, we have the ability to construct the images in the sagittal coronal axial planes without the patient in the scanner. The philosophy of the 3D sequences is applying the 3D MR pulse sequence, post-processing, and it will be ready for evaluation for the radiologist. Number of limitations of the 3D sequences, long acquisition time and reduced image quality. The long of acquisition time increased the risk of motion artifact, especially for patients with acute pain and pediatric patients. And we can see here is a good example for the motion artifact and an image with no motion artifact. Okay, I will go directly to, we did a study, my team and I. We reduced the acquisition time for 3 of the 3D sequences from 11 minutes to 6 minutes and etc. Then we applied the sequences on a phantom to calculate the numerical indices of SNR, signal intensity uniformity, and percentage signal ghosting. After that, we applied these optimized sequences to healthy volunteers to be sure that these sequences have the ability to show or visualize the normal anatomical structures. After that, we applied these sequences on 57 patients with suspected cartilage defects, and we found that 161 confirmed cartilage lesions distributed by grade 2 and grade 3. 3D TrueFISP, we found one of the 3D sequences has the highest sensitivity for detecting cartilage lesions. Excellent inter-observer agreement was recorded. Sensitivity were low.
1 minute more.
Okay. Sensitivity and specificity were lower for detecting low cartilage defects, high sensitivity and specificity values for 3D sequences with high-grade cartilage abnormalities. Here is a good example of the low-grade cartilage defect. We found that TrueFISP and SPACE FATSAT were able to detect the abnormality, while SPACE failed to catch the abnormality because of the blurriness and low image quality. Here is an example of the high-grade cartilage defect. All of the sequences successfully detected the abnormality. Quantitative findings were in line with our qualitative findings. We can see that TrueFISP has or attained the highest values for seeing contrast between joint fluid and cartilage. Advantages of 3D sequences: obtaining 3 orientation in a single sequence, minimizing partial volume averaging artifact, comprehensive coverage. Disadvantage: low image quality and long acquisition time. To summarize this, combination of 2D and 3D sequences will increase diagnostic confidence when evaluating the knee joint. Optimized 3D sequence formed clinically valid scanning options. Optimized 3D TrueFISP might replace multiple or at least one of the 2D sequences to increase diagnostic confidence. Hardware and software advances may improve the clinical utility of 3D images. We have here an example of that.
Thank you, Dr. Osama.
Yeah, it's like last one. So TrueFISP 3T, and we have advanced MRI scanner, 7T. We can see the big difference between them, but this machine is for research purposes and not yet for clinical purposes. For further reading, this is an article was published at European Radiology 2 years ago. Thank you so much.
Thank you.
Thank you, Dr. Osama. Our next speaker is Professor Mamdouh Mahfouz, who's a professor of radiology, Faculty of Medicine, Cairo University. He's the chairman of the Scientific Society of Radiology, Egypt, and he's head of research and continuous education unit in the radiology department, Cairo University. Professor Mamdouh holds an MD degree in radio diagnosis, and he's going to talk to us about sports injuries, about the hip imaging dilemma.
Thank you, Mr. Chairman. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. The talk is about the sport injuries around the knee joint, and actually we have 4 modalities for imaging in this particular area. The first one is the X-rays, and the X-rays are concerned with the detection of fractures, the detection of osseous tendon avulsion, some of the arthropathies, also assessment of avascular necrosis, and actually an initial assessment of femoroacetabular impingement. Ultrasound, which is a major diagnostic tool in this domain, because of its great advantages, being a fast machine and a very sensitive technique, non-invasive, and is a portable machine with real-time dynamic imaging and also had the Doppler facilities. The CT scan is concerned with detection of fractures that cannot be detected by the plain films. Also in preoperative evaluation of the complex fractures. Also it can identify intra-articular loose bodies and can be used with arthrography whenever MRI is contraindicated. The major tool for diagnosis of such lesions is the MRI. It is able to detect subtle stress fractures, avulsion injuries, liberal pathology, femoroacetabular impingement, and also the help of MR arthrography will delineate some of the internal derangement of the hip joint. We would like to have few words about each of these items, and we start by the stress fractures, which are one of the common lesions that can produce pain in such area, and commonly these fractures are present in the medial aspect of the femoral neck, as you can see in this MRI image. Many of the stress fractures are not actually detected by the plain film, and we need further evaluation by CT or MRI. And there are a lot of grading systems for the assessment of stress fractures in the femoral neck. And this grading system is obtained by MRI. Whenever you see some edema along the periosteum and subcortical edema, then whenever you see the fracture line, then you know that you are in the grade 4. Grade 4 stress fractures requires longer periods of rest and cessation of sport-related activities and non-weight-bearing technique. Then if you look carefully to this plain X-ray, and you can hardly see a fracture in the femoral neck, but this is the CT scan, you can see the fracture site, and by MRI, you can see also the fracture site surrounded by extensive perifocal edema of low signal in the T1 and high signal in the T2. Then the second issue is what's known as adductor insertion avulsion syndrome. And this lesion affects the medial aspect of the middle third of the femoral shaft, where the adductor group are attached. Then due to repetitive trauma, and there is some strain in this particular area, so you will see in the MRI some of the bone marrow edema at the insertion site, and also you may detect some periosteal increased signal due to edema as well. In the plain film, you may got some cortical thickening and periosteal reaction, while in the CT scan, this is the usual appearance where you can see the some periosteal reaction along the medial aspect of the middle third of the femoral shaft, and by MRI, you can see the periosteal reaction as well as the surrounding edema. And in the sagittal image, you can easily detect the perifocal edema and the periosteal edema as well. One of the rare lesions in sport medicine is the posterior hip dislocation or subluxation, which is frequently seen in contact sports and is commonly mistaken for a sprain in the hip. This lesion requires specific attention for the complications, especially what concerns about the development of a vascular necrosis of the femoral head due to disturbance of the blood supply. CT in these cases is able to detect the fracture lines and to see the integrity of the acetabulum, and also to detect intra-articular bone fragments, while MRI is able to detect bone marrow and muscle edema. And here we can use the dynamic contrast enhanced MRI to detect the vascularity of the femoral head. And whenever you got hypoperfusion of the femoral head, you are afraid about the development of a vascular necrosis. Also, whenever you have an arthroscopic examination, you may find an associated labral tears, chondral disease, ligamentum teres tears, and intra-articular loose bodies. And this is an example of dislocated hip on the left side associated with a stabular fracture. This is the femoral head displaced posteriorly. Then avulsion injuries of the apophyses is also common because the physis is one of the weakest point. It is more weak than the bony attachments, and the repeated traction and microtrauma to the physis will result in what is wrongly called apophysitis. It is not, but it is a reaction to the trauma. One of the common areas is the iliac crest, and you can see an example by the plain film, and this is a particular injury in such a kind of sport. Also, you may got avulsion of the anterior superior iliac spine, like in this example, and if you give time for healing and you see some reactive bone sclerosis around the fracture site, and this is also an example of avulsion of the anterior superior iliac spine. An MRI, you can see these bone marrow changes in the form of edema of the bone marrow, as well as edema surrounding the affected physis. Then we came to the femoroacetabular impingement, and we have two types, the CAM type and the Pincer type. In the CAM type, there is abnormal remodeling of the femoral neck with a bump of bone in this particular area, which hinders the extension of the hip and initiate or predispose for early damage of the acetabular labrum. And this is the CAM type by plain X-ray. This is the femoral neck normally, and here you can see a bump or bony projection in its superior aspect. And by plain film, you can see bilateral CAM type of femoroacetabular impingement on the left side and on the right side. The second type is the Pincer type, where you got more coverage of the femoral head by the acetabular roof, and this is because of the os acetabuli or the abnormal position of the femoral head, such in cases of protrusio acetabuli, for example. Then here you can see that the femoral head is covered for a large distance compared to the normal, and this is how to measure if it is normal or not. You consider the femoral head as a circle, and you put a dot in the center of the circle. You draw a perpendicular line from this dot, and then you connected the dot to the anterior inferior iliac spine or the acetabular margin. Then you measure the angle in between, and this angle should not exceed 39 degrees. If it is larger like this, and you got more coverage of the acetabulum of the head by the acetabulum, what is known as Pincer type of femoroacetabular impingement, and sometimes you can get both conditions together in the same patient. You can get the CAM type together with more coverage of denoting the Pincer type as well. Then we came to the acetabular labrum, and you know it's formed of fibrocartilaginous structure, which is triangular in shape and is black in all MR images. And if for better evaluation of the acetabular labrum, you should have MR arthrogram. I mean, you inject contrast material inside the hip joint to see the acetabular labrum, and this is the normal appearance of the labrum. And here is the normal appearance of the anterior labrum, which is triangular in shape, and also the posterior labrum as well. Then this is just an example of partial labral tears. Acetabular labrum can be torn completely or partially or degenerated. And this is an example of partial labral tear. And you see the contrast material is going through the cleft of the torn labrum. And this is also another example of torn anterior labrum with contrast material going inside the torn labrum, which is not anywhere black as usual. Then you see this is the normal anterior labrum with triangular in shape with black signal, and you can compare to the torn one. Another example where you got severe degenerative changes of the superior labrum compared to the normal one. Also, one of the signs of labral tears is the presence of what is known as paralabral cyst, where you got accumulation of fluid near the affected labrum. And this is taken as an indirect sign of associated labral tear. Also, what's known as os acetabuli, which was considered previously a non-united ossification center, is now considered one of the diagnostic signs of labral tears that has been calcified. Then we came to the ligamentum teres, and this is the normal appearance of the ligamentum teres. It arises from the transverse ligament and is connected to the fovea capitis in the femoral head, and it is thought to be one of the stabilizers of the hip joint. If in cases of abduction and extension of the hip, the ligamentum teres will be strengthened to support the hip from the posterior inferior aspect. Then the ligamentum teres is black in all pulse sequences, but if you see that the ligamentum teres is swollen and of gray signal, you know that is degenerated. And sometimes there is no ligamentum teres in the hip, like in this example, and you can see this is the normal appearance of the ligamentum teres, and this is the ligamentum teres which is enlarged and of gray signal denoting degeneration. And here is an example of partial tear of the ligamentum teres, and you can see a cleft within the ligament filled with contrast material. Then we came to what's known as greater trochanteric pain syndrome, and this is a pathology which affects the tendons inserting into the greater tuberosity, particularly the gluteus minimus and the gluteus maximus muscle, as well as the bursa. We have 3 bursa here in this particular area. If anyone is inflamed, a fluid collection will be seen on MRI. And here is an example of rupture of the tendon of the gluteus medius muscle, and the rupture is surrounded by fluid signal. And in this particular case, you see fluid along the greater trochanter, denoting greater trochanteric bursitis. And sometimes you got calcification in an inflamed tendon, and this is known as calcific tendonitis, either of the gluteus medius or the gluteus minimus or both. And this is just an example of gluteus medius tendinosis. The tendon, whenever it is normal, it should be black in all MR images. If you see the tendon gray, this is tendinosis or tendinopathy, and you can compare with the normal appearance of the tendon here. Then this is the gluteus minimus muscle tendon, which is normal, but it is surrounded by fluid signal denoting peritendinous inflammation. Another entity is calcium, which is located here bilaterally at the greater tuberosity, at the greater trochanter in this particular disease, which is known as calcium dihydrate pyrophosphate deposition disease. And you know that this disease is self-limiting and it can resolve spontaneously, as you can see here. Then we came to muscle injuries, and this is a frequent injury in sport medicine, and it represents about 30% of sport-related injuries. And we have 3 types of muscle injury. Number 1 is muscle edema, which denotes a grade 1 injury, muscle hematoma, denoting grade 2 injury, muscle laceration, denoting grade 3 injury. Edema in the muscle will appear bright in the MRI T2 weighted images, and it has a fizzery appearance like this, and because the weakest point of the muscle is the myotendinous junction, and here you can see the fluid signal along the myotendinous junction. Very nice example for muscle edema. And this is the clinical grading of muscle injury: grade 1 pain, grade 2 pain and weakness, grade 3 and the pain, weakness, and loss of function. And actually, there is a different correlation between the grading, the clinical grading, and the radiological grading. If you look carefully here and you see the adductor muscle is black in the T1 and bright in the T2, denoting muscle edema, and the edema is very well demonstrated in these fat suppressed images. Also here, this is the normal appearance of the muscles, and here you can got the edematous changes in the muscle. Whenever there is a hematoma, which is bright in the T1 and bright in the T2, you know that you are dealing with grade 2 muscle injury. And this is another appearance of muscle hematoma. You see a bright signal in the T1 and a bright signal in the T2, then this is hemorrhage. But if you got muscle laceration and by time you got muscle atrophy, then you are in the stage 3 of muscle injury. Here is the biceps femoris compared to the normal side, and the muscle is atrophic, replaced by fat with severe thickening of its related tendon. And this is avulsion, injury of the adductor insertion at the pubic symphysis, like this demonstration. And also you may got injury of the adductor longus muscle. Here in the T1, you got some bright signal denoting hemorrhage, and extensive bright signal in the T2 denoting muscle edema. And in the coronal images, you can see the extensive muscle laceration in this particular area. And this is a nice example of hamstring avulsion. The hamstring tendon insert in the ischium, and this is the normal appearance of the hamstring, and this is the avulsed tendon bilaterally surrounded by fluid signal. And this is also one of the injuries seen in the sport medicine, which is known as Morel-Lavalier disease, which happens due to shear injury between the skin and the subcutaneous tissues, resulting in injuries of the blood vessels and lymphatics, with leakage of lymph and blood in the subcutaneous space, resulting in a big cystic accumulation of fluid. This is one of the known lesions in sport injuries. This can be treated conservatively. It can be also diagnosed by ultrasound, and they said that aspiration of this fluid will recur, but if the best way for treatment is surgical excision. Then we came to the snapping hip syndrome, and snap means an audible or palpable sound when you flex or extend the hip joint. And we have 3 types of snapping. The external snap, which is related to the movement of the gluteus maximus and the iliotibial band over the greater tuberosity. And the internal snapping is related to the movement of the iliopsoas tendon over the anterior aspect of the hip joint. And this is the internal snapping, where you can see the iliopsoas tendon while moving the hip, which will snap on the anterior aspect of the hip joint. Actually, the MRI findings are not specific. They only see some tendinous edema and muscular edema, but the best way for evaluation is the dynamic ultrasound, where you can see the muscle during its snap. And this is an iliopsoas tendinopathy, which is one of the causes of a snapping hip. And if you follow the tendon in all sections, then you can see that the tendon is becoming swollen and is surrounded by fluid signal. And this is the the intra-articular snap, which is related to a pathology inside the joint, including labral tears, cartilage flap, loose bodies, and others. Finally, I want to say something about the athletic pubalgia, which is mistakenly known as a sports hernia. And this is an abnormality at the pubic symphysis related to the insertion of the rectus abdominis muscle as well as the adductor longus in the anterior aspect of the pubic bone. And this athletic pubalgia, you can see bone marrow changes in the symphysis pubis. You can see erosions of the pubic symphysis, and you can see some widening and also changes in the ligamentous insertion. And these are the MRI findings in such a case, where you see the abnormal bone marrow signal, irregularity of the pubic symphysis and the fluid signal. And also this is another case of athletic pubalgia. And thank you very much.
Now our next speaker, Professor Dr. Khalid Khoshhal, Department of Orthopedics, Taiba University. Dr. Khalid is an editor, chief of journal at Taiba University Medical Sciences. He's also founder, editor, chief of Journal Musculoskeletal Surgery and Research, and he is also professor, and Professor Dr. Khalid is a chair elect of AO Trauma Middle East and North Africa. Please, Dr. Khalid. He will talk about research education. Is it an option or a necessity? Please, Dr. Khalid.
So, just to start, if we have like show of hands, who of you think that research education is an option? Just like raise your hand if you think research education is an option. Okay, 3, 4. Who thinks it's a necessity that we need to? Thank you very much. So I don't think I need to present my presentation here. You're all convinced. You cannot preach here. All right. First, I'm going to talk about research education and not education in research. Not education and research. All right. So as Dr. Uthman mentioned, that I'm the editor-in-chief of 2 journals, the University Journal and another journal which is Musculoskeletal Surgery and Research. And from there, from the other journal, which is the Musculoskeletal, I had a recent article which was very interesting. A young researcher wrote a very nice article, and he wanted to send it to one of the Q1 journals in the field. So he thought that what is my probability of getting published? He looked at the journal, saw how many articles were published in that journal from the Arabic world. And he saw very few. So he said, like, for sure this journal is biased. They are against the Arabs. As usual, we have this conspiracy theory that we are like looked at differently. So he sent a letter to the editor-in-chief asking him about it. Okay? And let's see what was the answer. This is the letter that the answer was. It's very long, but the important part is that the answer to your query is very simple and straightforward and relates to research methodology and the soundness and originality of the research undertaken. We go down. Should high-quality studies from Arab countries be submitted, they will, of course, be considered. So, in summary of this letter, it's more that if you present something sound, it will be published anywhere. So, my objectives from this presentation is that first, we have to determine the importance of research for us, determine the importance of research education, and describe how can we improve the research education in our part of the world. So hopefully by the end of this lecture we can have some idea about it. So what is research for us? We know that there are so many definitions for research, but what is research for us as healthcare workers here? It's a systematic collection of information to learn more about a clinical phenomenon. We may have a different definition than other areas, but this is what is important for us in the healthcare as healthcare workers, either for medications, devices, diagnostic tools, treatment regimens, or protocols. So in short, it's intended to be for human use. This is what we talk about clinical research. When we entered into our field, our goals were that as healthcare workers, we wanted to prevent diseases and then treat the health problems. So if we could not prevent them, at least treat them. Reduce the suffering, and most importantly, is improve the patient's quality of life. And I think the rehabilitation program and the rehabilitation conference that we are in is more about improving the quality of life. So this is what we are after as healthcare workers. So why doing research is important? In our health sciences, it plays an important role in the country's economic growth. So we're talking now in larger scale. It's all about the whole country. It's not about only the patients. So it improves the economy, long-term sustainable development, and improvement in the standard of living and quality of life. Now we come back to the improving the quality of life. This is what we are after. The governments across the developed world have increased the research spending. Why? They want to improve their economies. So they understood this, that to improve their economies, to improve their quality of life of their population, they have to spend more in research. And I hope that we come into this status soon in our country here as well. So why doing it is important for us as healthcare workers? We always say that when we think about anything, we have to start with the why in mind. So this is important for us. If I want to do research, why should I do it? Is it important for me? This is what is important for us to understand. So initially, to find answer to a clinical problem. So if I have a problem, I have a patient who I don't know how to treat, I can go and research for that. Either search what is available or do a research myself to find a way to improve the condition of my patient. To build and advance the knowledge in the field that I'm working in. Because each of us, if we can provide a little bit of more information into the field, one piece with the other, then it makes the whole elephant. To stay up to date with the valid information, this is what we talk about as evidence-based medicine, evidence-based dentistry, evidence-based rehabilitation, so evidence-based. And again, we come back to our patients. This is where we all join the healthcare just to improve the patient care. So research will improve the patient care. Research is the engine that drives knowledge forward and empowers healthcare workers to learn by themselves. So that when we finish our studies as graduates, we will be responsible about our education from now on. So this is what we need to. So we need to learn more by ourselves, and this can be done while doing research. Design appropriate studies to support clinical practice. If I'm doing this, and I think it's right, I have to prove it. And to prove it, I have to provide an evidence for that. So this is another way, another importance of research. Build our data banks. And this is when we do large studies and we do like epidemiological studies and we do registries for our patients so we know when we come back to them what we should look for and what we are dealing with. Adopt the best diagnostic and treatment modalities. Promote feedback regarding the practice effectiveness, and this is the one important element, is feedback. So I'm doing this, I'm treating my patients in this way, and it helps. So when I study the outcome, I know that this way has helped more than the other way. So this is the one importance of research. Promote a change in attitude, because sometimes we face certain people working in the same field with certain attitudes. They think one way. It's a sort of an eminence point of view, eminent evidence. It's not evidence-based. So to change that, we need research to prove it. Level the patient's expectations, because all patients, they come to the clinic, they want to be back to normal. Can we do that? It's not always possible. So at least showing them the research available shows that this patient is going to improve 80% or 50%. Or this, our aim most of the time is to improve the current situation. We cannot always get them back to normal. And this has to be explained to the patients. And to do that, we have to have the evidence and have to have the proper research done. Healthcare workers are always encouraged to write and publish their results. And this was previously only an option. If you are interested, you can do it, or only done by the academician. But nowadays, with the Saudi Commission there, asking to join residency program, you have to have publications. So once you finish your graduate studies, you should have research. So we should learn how to do research much earlier than what we used to do before.
the number of scientific publications contributed by each university or country towards the global output has become one of the critical indicators. Now we are all aware of what is happening, which country is more, which country is better, which is the best 10 countries available in research. All these things are based on our research output. When we compare universities, which is the best university in this field or that field, so research is a very important part of this evaluation. So we have to improve it university-wide or nationwide as well. So what do we need? To have better research output, we need better conditions for training. So at least we need to know how to do research. So the know-how is important here. Promoting joint scientific activities. One hand cannot clap. So we need to join hands, join centers, join countries, join cities, universities, whatever. So one person cannot do it alone. So you need to join with your colleagues in the same department, the same university, or even different centers and different countries. And actually, the international collaboration between different countries is looked at much better than a study that comes from one center. Identify the use and strength of research centers, so we know what is available in the country, so we can get, instead of duplications, we can get to help each other by having whatever we have in our field. Stimulate multi-center projects, maximize human resources. If we have one expert technician in one university, we don't need to duplicate that. We can get use of him, so we utilize him most of his time. Improve the fund allocation for research, and this is important, although it's not in our hands, but we have to raise this point several times so it can reach to the authorities so they can improve the allocation of funds. In that sense, research is essential to challenge the current paradigms, provoke thoughts, and open mind to new ideas and skills. One example, this is something that goes into the history. Between 1818 and 1865, he was an early pioneer of antiseptic procedures. Ignaz found that there was a higher incidence of childbed fever in maternity wards staffed with doctors compared to those with midwives. So the wards that are deliveries done by doctors have more infections and more deaths compared to the wards that have midwives delivering babies. To start with, this is something that thought of not logical, because we always think that doctors are better than midwives. But in actual fact, what happened in that hospital, he looked into statistics and he found that. So he went ahead to trying to know why. He discovered that the incidence was drastically reduced after using hand disinfection. Especially those doctors were more involved in autopsies. So the doctor will do an autopsy here, then he go and deliver a lady there and go back to his autopsy without washing their hands in between. This was the reason behind the increased infection rate in the deliveries done by doctors. So it's a simple observation that led to reducing mortality drastically in the same hospital. So he proposed the practice of washing hands with chlorinated lime solutions in 1847. And unfortunately, till now, washing hands is not well practiced in hospitals. So translation of distinct clinical information into correct neurochemical vehicles. This clinical information he got, he translated it, then he defined the incidence of death due to the childbed fever, find the association between the cases and doctors performing the autopsies. He found this, now he has to translate it into a clinical judgment. Retranslate the information encoded in numbers into clinical language. What does that mean? It means that we have to change our practice to washing hands with chlorinated lime solutions. Hand washing is one of the most important tools in public health. So a simple observation led to a study led to a conclusion, when practiced, the outcome got better. This proves the importance of observing and the research behind it. So what is the relationship between research and education? The nature of education requires research as its fundamental base. Healthcare workers can only improve their skills and knowledge through inquiry. Otherwise, knowledge stagnates and becomes obsolete. The importance of research to achieve success in our profession is beyond the willingness or not to publish. So it's not, doing research is not only for publications. Although publications are important, but it's not only for that, it's for improving our practice and improving our patient care. Although medical research output in Arab countries, this was a study that was done in Lebanon and published in the Journal of Global Health.
Dr. Khalid, 5 minutes.
Okay. They found that the output increased over the last 10 years and is still lagging behind the rest of the world. Another study that was done here in Saudi Arabia, and it looked at the level of evidence, and they said that did not change significantly over the period of 15 years. So the type of research we're producing is not good enough, is not showing evidence, real evidence. In Latin America, there was a study that was done, and it showed a very small number of research coming there, but in the same time, the interest and motivation to perform scientific research was very high. So they utilized that by utilizing it, and then they came out with a conclusion they have to improve the situation, and they did a competency-based curriculum for improvement of research, a research education plan, performing research, technical and professional support, and assessment of the situation later on for a feedback to improve it further. So how to improve? We have to introduce the basic concept of research to all interested persons in a simple and didactic manner. It can be done through books, publications, presentations like in faculty development programs, e-learning courses or resources, lectures, workshops during courses, and the most important part, especially for our youngsters here, is that mentor-mentee research project for learning while performing research. So as a physician, as a healthcare worker, you take few students with you and you do research with them, so you tell them how to do the proper research and improve their situation. So in summary, it is educate. Educate your juniors to improve the outcome. The relationship, as we said, between education and research, they both take position against ignorance, and they both oppose the manipulation of truth and plagiarism. Research education, relatively inexpensive, highly effective. Although research may initially appear to be an optional activity, future directions in healthcare policies as well as our own edification requires an analysis of the efficacy of our treatment, and this is only possible if the healthcare worker learns and utilizes the appropriate research tools. When should we start? It's never too soon or too late to learn how to do and read research. To be a good writer, you must be a good reader. So you have to read published research before you start writing research. So the take-home message, clinical research must be performed to achieve progress in patient care. Research is a necessity, not an option. We can improve the research output by educating the new generation on the importance of research, how to read and write research, and how to publish. Research education can be face-to-face, e-learning courses, and mentoring. So there are different ways of doing it. It's not only one way. This topic was published recently in the Journal of Musculoskeletal Surgery and Research in the last issue, and I want to thank you all for listening to me. I hope that I hope that we go as seniors to teach our juniors and put our hands in their hands and come out with better research. Thank you very much.
Thank you very much, Dr. Khalid. It was, it was, a very important subject about, the importance. Dr. Khalid highlighted, give us the information and give us, shows us the importance of research. Now the last speaker is Dr. Rafiq Al-Momin Muhammad Radwan. He's a lecturer of Biomechanics and Ergonomics Department, Cairo University, Faculty of Physical Therapy, Egypt. He holds PhD of Biomechanics and Ergonomics, Cairo University. He was head of sport measurement and motion analysis of lab, Al-Ahli Saudi Soccer Academy, Jeddah. He was also head of medical team in the first soccer team at Al-Ahli Saudi Sport Club, Jeddah. He is founder of Physiki Center for Physical Therapy and Rehabilitation. He will be talk about soul's function of in runner, a new approach to treating BFP. Please, Doctor.
Okay. السلام عليكم. ربنا افتح بيننا وبين قومنا بالحق وأنت خير الفاتحين. I would like to thank the chairman for a kind introduction, and I would like to thank the Atiba University member for kind invitation for this presentation, and I hope it make a sense for the audience about this topic of the soleus and patellofemoral pain, or what is the role of the soleus as an introduction for if we use the soleus as an indicator to treat a patellofemoral pain. Okay, so patellofemoral dysfunction or patellofemoral pain is the pain coming from retropatellar or medial or lateral border of the patella. So this is a science which we can call it the patellofemoral dysfunction. And if I ask any one of the audience what is the cause of the patellofemoral dysfunction or chondromalacia patelli, all of us will say the disbalance or loss of activation of vastus medialis obliquus and loss of balance, loss of activation, and whatever all of this causes. You are right, okay. But let me change this word too. Patellofemoral is a dysfunction or the disease signed by the less activation of vastus medialis obliquus. But what is the intrinsic factor which make this vastus medialis obliquus have low activity or delay time of working during this issue? This is the core of our topic today. So, if we wanted to enumerate the factors of the intrinsic deficit of the players or runners or any persons, for the incidence of the patellofemoral dysfunction, one is the high vertical loading rate coming from the ground reaction force. And this happens in the early stance phase during walking or running. And the greater degree of the hip adduction, internal rotation, and medial rotation of the tibia like the photo you show. And this is a major position which make a lot of troubles actually in the lower limb, mainly affect the ACL and maybe lead to rupture of the ACL in the future. Okay, so adduction, internal rotation, and medial rotation of the tibia, and by the sequence, the pronation of the foot during movement. And reduced of the contralateral trunk leaning, which is low mobility of the trunk during the movement. A reduced ankle dorsiflexion, and this is due to loss of flexibility of the soleus or cuff at all, or impingement of the ankle joint. A reduced ankle dorsiflexion can be measured by many tests, but it's not our topics. An increased peak flexion angle on landing. So it means I don't have a good control of the knee flexion during landing. Okay. And overstride. So the persons who try to run with the overstride is decrease the activation of the gluteus medius and maximus, and this can happen and can affect the patellofemoral function, can go to pain, retropatellar pain, or chondromalacia patelli. Heavy landing patterns, this is a way or in a nature of the volleyball, tennis, or the players who coming to land many times during playing. an upright running posture, so it shifted the center of mass behind, and this is make a load on the patella and make a forward push to pushing the patella and make a more friction of the patella in the patellofemoral. And so, what is the soleus do during running? Before we can see the nature of the soleus in the MRI, it's represent about 52% of the total posterior cuff. It means it's a big muscles and it will produce a big force. Then the pinnate angle, or how the arrangement of the fiber of the muscles around the tendon, which is a greater pinnate angle, it make a production of the force very high of these muscles. And the soleus is the great pinnate angle among all the calf muscles. And it noted that it's larger in men than female by 15 degrees. So the soleus in muscles, as we said, it will produce a 50% of vertical support force during the running or walking, as it make at 52% of the shape of the calf muscles. And the soleus muscles in nature is a slow switch muscle fiber, about 80 to 90–60% of the fiber of the muscle is a slow twitch muscle fiber. It means the action of the muscle is going to improve the endurance and long time of contraction. And this is, we should highlight, because this is the main issue of the treatment, to use this type of exercise, which is endurance exercise to the soleus muscles, and the eccentric training, of course. So this is a biomechanical issue, which is two forces, one from the down of the leg, coming from the soleus, so we can analyze the vector of the force, and the others from the gluteus. It means the action of the soleus from the posterior and the action of the gluteus, action of the soleus from the leg, and the action of the gluteus maximus from the thigh, can make and force entire, make a control of knee flexion and assist knee extension. And that's why we can improve the power to improve the strength and control the flexion. So this is one important point of anyone to thinking about the human body. Okay, we are a linked pattern, we are a linked chain. So it's not necessarily the muscles go along the joints to act on this joint. And this is a good example during only stance. So the soleus and the gluteus muscles can control the flexion of the knee, and neither of them go inside the knee joint of the origin or insertion. Again, the soleus decelerate the leg through its action at the angle, and in nature is eccentric contraction to control the leg. And during controlling the leg, it's like a strong wedge, which make a propulsion of the trunk forward. So, the soleus, as we see, is very important in running, either controlling the foot, or controlling, make a propulsion to the trunk, or control the entire knee of the amount of flexion. How to assess the muscles? I think logic. We assess the muscle in two ways: the flexibility of the muscles and the strength of the muscle. So if we want to assess the flexibility of the muscles, this is the most test we can use. It's a half kneeling, knee to chest wall. So ask the patient to do that and measure the distance between the big toe and the wall and see how much the distance and compare it to the other side. Or use an inclinometer for measurement, the tibia inclination, and see the flexibility of the soleus muscle. Or we can go to measure the strength of the muscle by using the single leg soleus capacity testing, which is make knee flexion from 60 to 45 degrees and allow the patient to make like jumping or jogging and counting how much in 1 minute. This is the capacity of the soleus testing. This is a very simple way, but if we have a high technology like an isokinetic or or EMG dynamic, we can calculate these numbers actually from this machine. So if we want to rehab, I should you to remember what we say before. This is a slow switch muscle fiber, so endurance and eccentric training is the main way to increase the strength of the muscle, and the flexibility of the muscles is the way to improve the dorsiflexion and control of the function during running or walking. So improve the slow switch muscle fiber, improve the eccentric capacity of the muscles, and this is coming together. So the first exercise is a cycling exercise. When we do cycling exercise, the researchers record the degree from 45 degree to 135 degree during downstroke is the most activation of the soleus muscle. And be sure that you make it correct with the angle and also correct of the position of the foot. So put the pedal in the middle of the foot. This will activate the soleus muscles, and not put it in the front of the foot, because the activation will go to the calf more than the soleus muscle. And please don't use the two-clip pedal, and this is reduce the activity of the soleus muscle. And the second way, or the second training, is the balance training. Use an Athera band or an elastic ring to provide an hip adduction, external rotation, and knee flexion. And can you add a weight like that and make a mini squatting? And if you change the firm surface to a soft surface, it will facilitate and activate the soleus more and more. Okay. So the other thing is the way to strength, which is a concentric or eccentric training. I can use leg machines used for the strength of the quadriceps, but I will change or modify the position of the machine to put the handheld on the top of the knee, and we can use a step on the down to make an eccentric contraction of the soleus. So I can do the concentric by elevate up, and do the eccentric by allow it to control the deceleration down, as you see. And to improve the slow twitch or the endurance, I should make a high repetition. So at least 50 repetition is needed with a medium, one maximum repetition load. So I will not use a high load, but I will do a lot of the repetition during training. As you see, the angle of the knee is very important to keep between 60 and 90 degrees, and I can increase the weight from the machine. If I want to increase the elasticity of the muscles of the soleus, I can use the routine stretching or effective stretching exercise, or I can use a foam roll or a tennis ball to make a release of the myofascia and increase the elasticity of the muscles. As you see, I can use a pole, or I can use this position to make a static stretching, which is continue until 20 seconds of the stretching position. Okay, now, and this is a very important when you are looking for training or have the more activation of the soleus muscles, to increase the step rate during walking or running, as anyone who has this problem is going to do a high or long stride. So I will make him to make a step rate more and more. It's effectively to be 180 per minute. And if you see this diagram, with increasing the step rate, the forces of the soleus increase and the stresses on the patellofemoral is decreased during the joint reaction force. So at the end of this, it's a very specific point for treating of the patellofemoral issue, because if you follow this, you can find a lot of researchers speaking on a lot of modalities used to decrease these risk factors like the groin rehabilitation, so increasing the gluteus medius, increasing the gluteus medius, increasing the core stability program, and then using a local treatment on the patellofemoral or iliotibial band, and hence we add another point of the soleus strength and endurance eccentric and a low rate step in this issue of the topic to make it a very efficient in the treating of the patellofemoral dysfunction. And wait. Breathing exercise. Before I can tell you my home message, I will ask you to have a deep breathing exercise, and actually you should follow me, so you should have an inhalation. All of the audience is allowed to do that to finalize this presentation. So please take deep inspiration and put your hands in your abdomen. Yeah, and then hold. Then exhale, continue exhaling, then hold, and then repeat it, please. Inhalation from the abdominal, it means diaphragmatic, hold, then exhale, continue, hold. Thank you. This is not a joke. It's one of the big exercise we are missing in our rehabilitation because we neglect the diaphragmatic as one of the core stability, and we should concentrate in this issue if we want to continue the core stability exercise. And finally, my message for you, our field is not specific for the injured part. Our field is specific for, as I see, or I heard this many times today, the quality of the life is our professional effect, or it's our rule to keep the quality of the life. And if we want to have a quality of the life, we should widen the scope to look for our whole body, not just the injured part. So widen the scope, please, if you're treating your patient, and look for the body. Try to specify the intrinsic defect factors and treat the whole body, not only the injured. Thank you.
Thank you, Dr. Rafiq Al-Mamoun. Thank you very much. By this, I'm inviting all the speakers, please, to come here and to answer if there's any questions. Any question from the audience? Yes, please.
السلام عليكم. سؤالي للدكتور خالد عن الريسيرش. Doctor, you have mentioned about the education that is a must and necessity. Of course, we all agree about this. But we all agree when we were in the college, a big number of us, according to my opinion, when we were in the college and studying research, it was a pain in the neck. It was educated to us by the most painful way. It was too much thing for us. It wasn't simplified at all. It was like a message from whoever was teaching it to show us that he didn't get it easy, and you shouldn't get it also easy. Even postgraduate, when we attended many courses, it was delivered to us by the most difficult way and most complicated and complex way. When we started to do some research projects, we were like moving many steps, and in each step they make us hang for a long time just of doing micro and micro and micro corrections. And I've read a lot of research reports in many big journals. Nothing was perfect, of course. Allah only is the perfect one. And why perfectionism was stressed on in educating research in such early stages of educating, of getting learned about research. So I think the biggest failure, in my opinion, for having low number of researchers in the Middle East, especially in our country, in my opinion, it is blamed to whoever was delivering this research education, because he wasn't really realistic and not moving from step to step and dealing with undergraduate and people who are dealing with research as something divine. It's something that should be so perfect. And I think this blocked a lot of people from having a passion to be a researcher to stop following this passion. What do you think about this?
Thank you for your question. I think when you ever start any project in your life, you have to start with the aim in with the end in mind. So if I want to write a research, it's my first research, I should start aiming at a low-level journal, so a low-level research, because it's my first start. If I'm going to send my paper to one of the Q1 journals, then it has to be perfect. Otherwise, they will not accept it. But my first project will not go to Q1 journal. It will go definitely to Q4. So we have to be realistic. I'm sorry that you had this difficulty in your teaching, but we cannot generalize it. I'm sure that different areas, different colleges, different universities, they have different teachers teaching research. And I hope that we can improve our research education so it can simplify the research, and we can take the first few steps in doing it. Our research output is not much, not because we had difficult teachers, because our output was not perfect enough. So sometimes you get teaching from somebody who was trained somewhere under a very meticulous supervisor, so he will be meticulous in his work. But we have to start knowing that my first research will not be perfect. If we start with this in mind, I think we can do our first paper, and then it can be sent to one of the local journals, because that will improve my research level. When I go through the whole process from doing a research, writing it, submitting it, getting the reviews back, improving it again, and sending it again. So the whole process of writing research to publication, this is important. I think we need several courses that are not for one class. It has to be, research education has to be generalized, because research is research. Whether you are in College of Medicine, dentistry, pharmacy, allied health or rehab, or nursing, it's the same. Research is the same. So the research elements and research education is the same. So we can do several courses, and I tell you, out of experience, I've done several courses all over the world now. Different areas that we have submitted our courses, and we have developed a new way of teaching it, and we have went through teaching seniors even in research. Research can be as easy as 1, 2, 3, and can be very difficult as learning Chinese.
Any more questions? Please. Your mic there, microphone.
Thank you.
No, here the question.
Sir, good afternoon. Thank you for talking such an extensive way about the research in the rehabilitation. I'm a professor at Manipal Academy of Higher Education, India. It is an university, deemed university in south of India. And as a student, what she has gone through, I agree with her opinion. I just give some suggestion, and after that I have some questions to you. I think whatever you have gone through, it is a common phenomena across all the students. The easy way is that if we can integrate the research and the clinical practice possibly you will find a better cohesion to organize yourself about what happens about the sampling, what happens about the statistical analysis, sample estimation, then finding out the answer of your research outcome from the available literature, and then commenting about your new findings. Absolutely what sir has commented, it is an extensive work, it is not so easy, but it is a way you mature, it is a way you learn. Another thing, sir, you discussed about the collaborative research, and you agree with me that collaborative research is the need of the hour if we have to publish our publication in Q1 journal, which is not so easy task. Now, I would like to know what viewpoint you have to facilitate the collaborative research, because in the rehabilitation, unless we proceed with that, maybe many of young generation may not be able to see the Q1 publication or Q2 publication, which is the need of the hour by many of the universities. Thank you, sir.
So please, I want short question and short answer because of the time. Please.
Okay. Yeah. Well, collaborative research is the best way of doing research, and collaborative research can be between different people in the same department, or different departments, or different even specialities. I cannot talk more about the importance of collaborative research because it finds its way to publication much easier when they see that there are different people from different specialities collaborating together. That research is looked at superior to the one that is a single author or a single department research. So this is an important thing. How to go with that is that the one with the initial idea has to look into who is involved in this. Like if I'm in rehab and I have like a rehabilitation of patients with knee injuries. So now this research will involve me as a rehab, and then those who are finding out these cases or treating them as surgeons, for example, or radiologists who are like picking them up, or like even other workers or even sports specialists. So we can combine them together. A coach of a team can be with you in the team, and then you can start. So an idea has to come from someone, and then he has to look for who is involved in this type of research, and then you call for the team and make your team and then start. So it cannot come out from somebody else. You have to raise the flag, and you have to start and put the bell first and then move from there.
Thank you, Dr. Khalid. So last two questions, please.
Assalamu alaikum. My question is from Dr. Osama, and congratulations for a lovely presentation on 2D and 3D MRI. I have a comment and then I have a question also. My comment is like your mean value was 41 years of age for knowing the cartilage injury. Mean value was 41 years of age. And the specificity, you said 94 to 99% was the specificity and reliability was. Me being a clinician, we know in 41 years of age, 100% of the population anywhere in the world will have some cartilage injury. And orthopedicians are sitting with us, he will agree with me. Now, when we send them for MRI, they will know that there is a problem in the cartilage. And we know the pain, majority of the time, pain does not come because of that injury. With the help of physical therapy, we are able to fix their problem. But when those patients go for MRI, will they not have psychological problem forever in their life? And then no matter what treatment you give, what procedure you give, they will still have pain. And
so please, Dr. Kumar, please, be short.
So my question is, yes, do we really need to send them for MRI to know whether there is a cartilage injury or not? Okay. When we can, and this will not change the treatment from rehabilitation point of view. So do we really need to send them for MRI?
So what's your...
So yeah, thank you. It's an interesting question. So usually the orthopedics send the patients to MRI if they have abnormalities, suspected abnormalities for sure. If we have subtle abnormality in the cartilage, we need to detect it, let's say, as early as we can. So before, to monitor the knee joint and to send sufficient information to the referring clinician about the status of their patient. I think after that, the treatment could be arthroscopy or physiotherapy. It depends on the patient's status. Yeah.
By this, thank you so much. I will conclude the session. This session. So no more question, please. And now, please, التكريم الآن ذكر السبيكر. Chairman, please. Chairman, دكتور تفضل دكتور عثمان.
سعادة الدكتور رفيق المأمون. سعادة الدكتور ممدوح محفوظ. سعادة الدكتور خالد خوشحال. سعادة الدكتور أسامة عبد العال. استراحة ربع ساعة للصلاة وبعدين نرجع نكمل البروجرام إن شاء الله.
نايف هتعلم عليه لانه لحد دلوقتي محدش لاقي. طيب يعني ممكن يحصل تبديل ولازم نتابع مع المحاضرين. دكتور سمير نفس المشكله يعني
سمير أسامة أو نايف الاثنين هذا مو تامر هناك
دكتور صلاح، دكتور صلاح ثانية. دكتور سمير بالضبط. لا المفروض يكون ليش لسه ايوه هيجي بس السيشن جاي. الساعة كام؟ لا بس احنا هذا الشيء
تمام خلاص وانت هتبقى مسؤول انك خلاص تتابع المحاضرين هم ولا لا؟ استنى ربنا يكرمك بس معلش بقى كنا دلوقتي في التمرين بحيث وقت ما قبل ما نمشي بس نحضرهم اه
طيب بص يا دكتور، ممكن نظبطيها بكره. انا ببقى موجود باذن الله بس يوم 7 ونص صباحا. ما في مشكله ان شاء الله. احنا حضرتك دكتوره الجهاز مش الجهاز ملوش مصير. ممكن تيجي حضرتك لو انا حصل ظرف ما جيتش تيجي على بس خلاص ان شاء الله. السلام عليكم. يا دكتور نايف اين انت؟ طيب عشان دكتور مصطفى الله يبارك فيك، كنا عايزين ناخد برزنتيشن نحطها بس على الديسكتوب. الله يجزاك خير. ماشي ماشي، انا موجود على الكمبيوتر. اتفضل مع السلامه عليكم. خلاص دكتور نايف دقيقتين حيكون هنا دكتور نايف. احمد معك فلاشة؟ إن شاء الله.
السيشن اللي جايه دكتور فيصل موجود صح؟ هتجيب لي السي في بتاعه لان دكتور حماده اتشال من السيشن دي كمان. تمام؟ هو اول واحد في السيشن اللي جاي على طول لان هو دكتور فايز. تمام ايوه بالظبط كده. تمام؟ شكرا 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 مع السلامه مع السلامه مع السلامه.
حضرتك يا فندم. تاني بالترتيب كده. انا اخر واحد، انا اخر واحد.
يبقى نمشي وانت
تاني انا اخر واحد.
قبل 5 دقائق.
انا خايفه عشان الرضا يتاخر. لا خلاص خلاص نبدل كده تمام.
هم طالبين انه يبقى نكتب الوقت قبل 5 دقائق يلبس.
بالظبط كده بالظبط. على المايك نخبط على المايك. ازي حضرتك يا دكتور؟
الله يسكت حالك. مساك طيبه. مساك بخير. خليكم دقيقين في الوقت، مش عاوزين المأساة حقت امس تتكرر.
على طول.
ها؟
هي السيشن 20 مينت مش كده يا دكتور؟ 20 مينت الليكتشر 20 مينت 20 لا اعتقد دي ولا 20 يعني كل سيشن بتختلف عن الثانيه.
دي من 10 ونص سوري من 12 ونص المفروض 12 و50 يعني 20 مينت. الموضوع عندنا اتفضل حضرتك يا دكتور. حضرتك هيبقى معاك دكتور نايم.
ماشي
تمام. بس ثيرد سبيكر
حماده هيبقى معانا اول السيشن الرابع.
بديل دكتور حضرتك فرصه في السيشن دي بس تبدل مع دكتور فايز. هو انا حضرتك
معانا.
السلام عليكم. نبدأ يا شباب. لو سمحتوا. الله يخليك. الله يخليك. طيب بسم الله الرحمن الرحيم. نبدأ الجزء اللي قبل الأخير اليوم إن شاء الله. دكتور هاجد العتيبي. He's the chairman and assistant professor, respiratory therapy department. He's in the College of Medical Rehabilitation Science, King Abdulaziz University, Saudi Arabia. He holds a PhD from the University of Nottingham. He is the chairman of Scientific Council for Health Rehabilitation, Saudi Commission of Health Specialists. He is the general supervisor at Respiratory Therapy Unit, King Abdulaziz University Hospital. Welcome, Dr. Hajid.
Thank you very much. Thank you very much. السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. First of all, I would like to thank the organizing committee for inviting me to participate in such great scientific events. Dr. Rafiq, before this session, he started with the breathing exercise, and I believe this is part of our job as a respiratory therapist. So I invite you all to take a deep breath and relax, because indeed it causes relaxation to the body. Today, I'm going to talk about the endurance shuttle walk test. We have in the respiratory therapy profession, we have a rehabilitation component, which is the pulmonary rehabilitation. And this one intersects with other rehabilitation profession. This is why rehabilitation in general is multidisciplinary team. There is an RT, PT, OT, psychologists or psychiatrists, social workers. So all have inputs on the rehabilitation program. So I will talk about the endurance shuttle walk test. I need to use this one. This is my outlines. I'll have offer a few. Then I'll talk about the test. Then its development, validation, response to pulmonary rehabilitation, and conclusion. So usually most of the activities of the daily living, which is very important for a patient with pulmonary disease, it usually runs at submaximal level. Therefore, we need to measure their ability to sustain submaximal activity. And there are several proposed tests, these usually called field tests, that are used to measure the functional capacity of patients with pulmonary diseases. Because to decide about the severity of the disease, some of them, they are using the pulmonary function testings. These objective parameters, they did not find it is correlate with the severity of the disease. It's not important, these numbers, for me. The important is the functional capacity of the patient, what the patient can do. How can I measure this functional capacity? There are several field tests, like the 6-minute walk test, or the 12-minute walk test, or the incremental endurance, or the incremental shuttle walk test. The 6-minute walk test, basically, it is just, it can be done, and I cannot see this one. It's okay. You can see this diagram. The 6-minute walk test is just you put 2 cones in the hospital corridor, 30 minutes apart, and simply you ask the patient to walk from one cone to the other cone until they get tired, and you measure the distance. And the distance is the component that used to assess the functional capacity or the exercise capacity of the patient. So after the patient is undergo rehabilitation program, you redo the test again and you measure the distance. If there is an improvement by 54 meters or more, that means the program is effective. But the 6-minute walk test is not really sensitive for the rehabilitation program. So they came up with the endurance shuttle walk test. This is a constant load exercise. The speed is constant, which measures the ability of the patient to sustain a given submaximal في الليزر. اوكي طيب ممتاز. طيب. So it's a constant load exercise which measures the ability of the patient to sustain a given submaximal activity. There are 16 levels of the speeds for the endurance shuttle walk test. You need to select the speed that suits the patient, and I'm going to tell you how you going to select this speed. The primary measures or the primary outcome of the endurance shuttle walk test is the time. How many minutes the patient is able to sustain walking at this speed. This is very important. And sometimes you need to do it 2 times to get rid of the learning effect. So the operator will terminate the test or will consider the test is done if the patient fails to reach the cone or the patient is away from the cone by more than 0.5 meters. That means the patient cannot sustain the speed that enable him or her to finish the 10 meters during the predetermined time. So when the patient is just outside the 0.5 meters marker, they are advised for the first time to increase their speeds. But if they fail to increase their speed, that means the clinician or the healthcare providers need to end the test. The test also can be ended if the oxygen saturation is dropped below 80%. So the endurance shuttle walk test has been developed 20 years ago in 1999 by Revel and his group. Those people, they tested several frequencies. This is a systemic test, whereas you do not need to do anything. You just to bring a cassette, and when the patient hear the beep, they walk until the end of the 10 meters where there is a cone. Then the second beep, patient will hear the second beep, and they will go and walk around it. So, it's, as I mentioned, it's a 10-meter shuttle course. A patient were instructed to walk along the course, turning around the cones at either end in time with audio signal from the cassette player. So the instruction, as I mentioned earlier, is to continue walking until the patient is tired or breathless. Speed, as I mentioned, it is determined based on the approximate value of the peak oxygen consumption. That means you need to do incremental test or incremental shuttle walk before you do the endurance shuttle walk. I'm going to tell you how you're going to do it. So this is an example. We have a patient with chronic obstructive pulmonary disease, and we did the incremental shuttle walk test to measure the maximal oxygen consumption or to predict the maximal oxygen consumption, and the patient was able to walk for 320 meters. So from this one, I can go and insert it in this equation, which is a regression equation to measure or to calculate the maximal oxygen consumption, which is here is 12.2 mil per minute per kg. And once you know the maximal or the predicted maximal oxygen uptake, you need to decide at which level patient should walk, at which submaximal level, either 75%, 85%, or 95%. And this is depend on the hospital protocol, which differ from hospital to another hospital. So based on that one, I will select the 85%. I need to run the test at 85 submaximal oxygen test of 85%. Then I will go to this graph. I will use this graph to determine the speed. So I will go to the 10.3. Then I will determine the speed, which is 4.3. Then I need to select which level of the cassette or the beep that I'm gonna to use. I need to use this schedule. So if I'm talking about of a speed of 4.3 kilometer per hour, I'm talking about level number 10. Simple as that. Then you play the cassette or the tape, which has the duration from one end to other end is only 8.3 seconds. Patient need to finish the 10 meters within 8.3 seconds. So this is how this is the overview of the endurance shuttle walk test. The authors has tested the repeatability of the test. If the patient repeat the test, can we get similar result? And this is what they have done. They found that the test is repeatable. In the first time, they got 110 seconds. In the second test, they get a similar number, which is 325. And the authors assess the sensitivity of the test to the pulmonary rehabilitation program. They get 21 patients, and they have a control period for these 21 patients. They run the ASWT at the beginning of the control period. and at the end of the control period, which is 5 weeks. Then after the 5 weeks, they started the pulmonary rehabilitation program for 7 weeks, and they repeated the endurance shuttle walk test. So for the control period, they found there is no changes. Oh, definitely, we are not expecting any changes because patient is not engaged in pulmonary rehabilitation program. But when they finish or completed the rehabilitation program, the endurance shuttle walk test has increased to almost to the double. That means the program is effective, and the endurance shuttle walk test was sensitive to the changes in the functional capacity of the patient. So authors believe this test is very sensitive to pulmonary rehabilitation program. If you can see here, they also tested the incremental shuttle walk test, which is another field test, and there is a changes, 178 and 215. It is not like the changes that was produced by the endurance shuttle walk test. The endurance shuttle walk test was more responsive to the patient changes in the functional capacity compared to the incremental shuttle walk test. This graph will show you again the changes in the endurance shuttle walk test compared to the incremental shuttle walk test. Another studies published, I guess, 2006, they again tested the hypothesis that the endurance shuttle walk test is responsive and sensitive to the pulmonary rehabilitation program. And they compare it to the common test, which is 6-minute walk test. It is very common, and it's been running in all hospitals, the 6-minute walk test. And this is the inclusion criteria. They selected moderate to severe COPD patient, clinically stable, and they designed an 8-week rehabilitation program, 2 sessions per week, and the rehabilitation program included supervised training, which is included aerobic treadmill, cycling, and thoracic mobility, and counseling and educational session, which included self-management, dyspnea coping strategy, nutrition and lifestyle strategy, and they ask the patient to do some exercises at home. So this is very intensive rehabilitation program, and they measure the pulmonary function parameter, which is the forced vital capacity maneuver. They run the 6-minute walk test, endurance shuttle walk test, and health-related quality life questionnaire. What they have found, there is no changes in the pulmonary function testing after the rehabilitation program. And I would comment on this one. Pulmonary function testing or spirometry is effort dependent. So it depends on the patient effort. So probably the patient effort is sub-maximal in before the pulmonary rehabilitation program, and the result will be very low, and probably it will be maximal after the rehabilitation program, and the result will be very high. But this does not reflect changes is related to the pulmonary rehabilitation program. In the endurance shuttle walk test, the distance has increased from 313 to 633, and the time from 5.1 to 9.6. The 6-minute walk test, the distance has increased from 351 to 420. See, there is a small increment and increase in the 6-minute walk test, but the distance will not be compared to the endurance shuttle walk test. Again, I'll finish inshallah in time. So this is the graph. So the conclusion, of this study, the endurance shuttle walk test is highly responsive outcome measure for pulmonary rehabilitation, and it has the potential advantage in that it may be more responsive. Another study has used a medication, salmeterol, to the group to see if the endurance shuttle walk test would assist and be responsive to the medication. And here is the result. They found a significant changes in the pulmonary function and in the residual volume. There is also a changes in the salmeterol group compared to the placebo group. That means the endurance shuttle walk test is very responsive even to the medication. The last one, they evaluate the endurance shuttle walk test with the patient in oxygen therapy, and they have found that those patients in oxygen therapy, there is significant improvement in endurance shuttle walk test, either in distance or in time, and there is small improvement in the 6-minute walk test. And this is the graph would show you, and the conclusion, endurance shuttle walk test is a responsive tool that could be used to explore and monitor the effect of ambulatory oxygen. And this comes to end my presentation, which I hope it was helpful, and you will go back to your hospitals and adapt endurance shuttle walk test as a measure of the outcomes of pulmonary rehabilitation program. Thank you.
Thank you, Dr. Hajid, for this actually a great lecture and a new technique, actually, which is not used in a lot of hospitals. I hope really to be start in all hospitals, and we started in Medina, inshallah. Thank you.
Bismillah ar-Rahman ar-Rahim. I would like to invite Dr. Prof. Samir Gazzar to present his talk. Dr. Samir is the Dean Physical Therapy College, Heliopolis University, Egypt. He was Professor and Dean of College of Physical Therapy in Batarji Medical University, Saudi Arabia. Also was an Associate Professor of Physical Therapy in King Faisal University. He holds his PhD, Physical Therapy Rehabilitation, Cairo University, and also from Indiana University, USA. Prof. Samir holds State Board Physical Therapy and Rehab, Chicago, USA. The title of his talk is "The Study Investigate How Physical Exercise Protect Against Sudden Cardiac Death."
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم. Thank you, Mr. Chairman. Thank you, my dear respected chairperson, colleagues. First, I would like to extend my great, profound gratitude to the organizing committee headed by Professor Dr. Abdullah Shinqiti and Dr. Salah, Dr. Mustafa. And I am proud to start such conference from scratching point. We started this conference 12 years back, starting with mini conference, half-day conference, until will be international conference. Alhamdulillah. Me, actually, I'm so proud and happy to working at Saudi Arabia more than 15 years back, and I am the one starting the second BSc degree at King Faisal University 20 years back. And right now my students almost head department or dean college or famous in physiotherapy. And after that I will make first batch at King Faisal University and then transfer to private college, Batargi Medical College. And also we have more than 8 batches. Me right now, I am originally from Cairo University, department head, and right now Dean College at Heliopolis University. And take care about the name of our university right now, Heliopolis University for Sustainable Development. Sustainable development means how can we introduce, how can we address the sustainability in physical therapy and rehabilitation field. By the way, my talk today related to a new investigation how physical exercise protect against the sudden cardiac arrest or sudden cardiac death. نبوءة من نبوءات المصطفى صلى الله عليه وسلم وهي موت الفجأة. بقينا نسمع كتير قوي عن موت الفجأة especially في اليانج adult, young category. how can we make preventive measures in physiotherapy? We are not only treatable measures, we have to address the preventive measures from physiotherapy point of view, and as well the importance of sustainability in physiotherapy field. Millions of people experience irregular or abnormal heartbeats called arrhythmia. And I think somebody right now sitting with us having some sort of arrhythmia or extrasystole or irregular heartbeat. And most of the time they are harmless and happen in healthy people free of heart disease. Normal subject. Some abnormal heart rhythm can be serious or even deadly. Why this research? Because sudden cardiac arrest or sudden cardiac death can happen in people without heart disease. Suddenly, everything is gonna suddenly. Lifestyle changes during reducing the risk of sudden cardiac arrest. And every physiotherapist should divert his attention regarding how to change the lifestyle of not only our patient, but also our client. And not only might be for all the society, how to change the lifestyle to be a healthy environmental lifestyle. Largest cause of natural death in states, 350,000 each year. Now we don't have statistics in our country, as everybody knows. But when we talk about 350,000 في السنة بيموت without any cause, it might be disaster. وإحنا بنسمع يعني even the young adult athletic sudden death. We can decrease also your chance of having a heart attack or dying suddenly. Common cause of death in athletes with incidence of around 1 in 40,000 per year. Sudden cardiac arrest death totally annual is more than for the breast cancer, lung cancer, and HIV or combined. I think it might be disaster. More than breast and lung cancer and even HIV. We have specific fast facts. Young competitive athletes die suddenly every 3 days. Every 3 days. Young athletes are more than twice experience sudden cardiac death than young non-athletes. Most victims are male, so or female are lucky, 90%. The average age when sudden cardiac arrest occurs in young athletes around 20 years old. 2/3 young athletes die suddenly are basketball and football players, and consider in around 65%, 67%. Risk and prevention, family history of unexpected, unexplained sudden death in a young person, fainting or syncope or seizures during exercise and excitement. And you should take care about your patient while making some exercise, while making some aerobic, while making some programs at your clinic, at your hospital. Take care about, and you have to take in your consideration the importance of seizures, fainting, syncope, and even for yourself and your family. Consistent or unusual chest pain and or shortness of breath during exercise. And we have other important things. Coaches are key to preventing sudden cardiac arrest in young athletes. Sometimes now we are working as a teamwork. In our team, we have several persons in paramedical and as well in medical field. So sometimes coaches or trainer or personal trainer might take a very big mistake while approach the person. I would like to acknowledge a group of researchers from physical therapy, faculty of pharmacy, faculty of engineering at our college, and those are my right hand and my eyes. Disease and disorders in brief related to the heart disease, we have it might be either electrical or structural or organic. Electrical one, abnormal heart arrhythmia problem with electrical system regulates the steady heartbeats or heart rates. May be too slow or too fast. It may stay steady or become irregular or disorganized, just like atrial fibrillation, atrial flutter, some sort of syncope, transient syncope, or even ventricular tachycardia or ventricular fibrillation. And by the way, I suffered from atrial fibrillation 10 years back due to some sort of excitement and distress in our work, and everybody vulnerable to have such fibrillation. Some are very dangerous and they cause sudden cardiac death, while others may be bothersome but not life-threatening. Or the other category, it might be circulatory in nature, high blood pressure, coronary artery disease. And I think right now we have a big category of our youth or our young aged have a blood pressure. And it might be primary hypertensive or primary hypertension due to smoking, could be due to lifestyle change, due to sports, due to stress, excitement, causing a blockage in the pipes, supply blood to the heart, result in a stroke or heart attack, which can be devastating, and one of the devastating calamities right now. Fortunately, there are many preventive and treatment options related to strokes, brain attacks, or heart attack, myocardial infarction. And the last one is structural heart muscle disease. It could be cardiomyopathy or congenital abnormalities in spares, or two problems that can damage the heart muscle or valve in form of heart failure or valve problem. Hypothesis: moderate aerobic physical exercise protect against sudden cardiac death. And when we talk about aerobic physical exercise, it is so much important. Actually, we have more than 100 beneficial effects of aerobic exercise for all body system. I have 12 published papers related to aerobic exercise affecting all body system, might be renal function, liver enzymes, and even digestion, and relieving of stress upon your joint. Aerobic physical exercise has been suggested as a non-pharmacological treatment against arrhythmias. والآن احنا بنقول دور العلاج الطبيعي في الحملات القومية. ازاي نعالج العلاج الطبيعي؟ ازاي العلاج الطبيعي يتعامل مع مرضى ضغط الدم الأولي البرايمري، الشباب اللي عندهم ضغط دم وهو مش واخد باله، ازاي يعالجه من غير ما ياخد أدوية ويصبح مريض ضغط؟ وده اللي بنقول عليه النار pharmacological approach against arrhythmias. Supposition and assumption research try to clarify that the application of an aerobic physical exercise protocol in sedentary animals, lab rabbits. We are dealing with the animal house at the pharmacy college and they make the research and they can have a beneficial effect on electrical properties. And while we are talking about electrical properties of the heart related to ventricular fibrillation, the exact underlying cardiovascular protection mechanism are not fully understood yet. Furthermore, they attempted to learn whether neurons that are in the heart, cholinergic neurons, play a role in the potential modification caused by moderate training or even mild training. The intrinsic electrophysiological heterogeneity and the modification to electrical stability, those are two main items dealing with, which is electrophysiological heterogeneity and as well electrical stability. Isolated rabbit heart studied the effect of prolonged physical exercise on aforementioned properties, including blocking the action of these neurons and as well upon the cardiac cell. In the isolated perfused rabbit heart, the training via protocol of physical exercise produced the end result: increased ventricular refractoriness, increase the ventricular impedance, decrease of ventricular electrophysiological heterogeneity, and as well increase in the electrical stability. properties have been modified in a beneficial way by applied physical exercise protocol, contributed to clarifying the basic mechanisms through which regular physical exercise has a protective effect against sudden cardiac arrest. Providing information on the participation of cholinergic cardiac neurons of the aforementioned modification, results obtained suggest the need to continue research in order to clarify the underlying mechanism of the observed modification. And as my colleagues talked yesterday about the importance of physical therapy, importance of physical therapy not only treating musculoskeletal disorders or treating the sports disorders, no. We have to divert the society attention about the sustainability and effectiveness of physiotherapy programs for all aging categories. We are, as a physical therapist, dealing with all aging categories. إحنا بنتعامل مع المريض since birth until death, until elderly. So how can maintain the sustainability of the lifestyle healthy approach in all aging categories? So you have to divert your attention about the task, the environment, individual, just to achieve the ideal sustainability of the person. Providing of Therefore, you have to relaunch it and turning your patient disability into ability, which we call the reablement, resettlement, readjustment, role fulfillment. And I would like to give your attention also about the plenty type or the plenty of colleges right now in King Saudi Arabia. 20 years back, I'm starting second BSc degree at King Faisal University called Al-Dammam right now, after King Saud. Right now, we have more than 15 college physical therapy at the kingdom. Why? يعني الناس دي هتتخرج Did you know how many college at Egypt right now? By second academic year, we will be 26 college of physical therapy, private and the governmental sector. Why? احنا ابتدينا جامعة القاهرة الكلية الوحيدة اللي صدرت العلاج الطبيعي للمنطقة ولأوروبا والأمريكا. النهارده 26 كلية والسعودية 15 في خلال 20 سنة كلية. So you have to be careful about a plenty. And right now, Dr. Hagid also respiratory therapy starting one. Right now, he told me more than 15 respiratory therapy college. Why? فين سوق العمل اللي So take care about. Please, your concern is greatly appreciated, and please rate us up before time over. And everybody invited to please see my website. And thank you so much, and thank you all for your attendance.
Thank you, Prof. Dr. Samir, about these beneficial lectures. Now for the third speaker.
بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم. I would like to introduce our speaker now is Dr. Naif Zahrani. Dr. Naif is a consultant of physical therapy cardiovascular rehabilitation. He is a senior specialist in physical therapy. He holds PhD at cardiovascular rehabilitation from University of Newcastle, United Kingdom. He is a physical therapist at Prince Sultan Military Medical City. His lecture title is Effects of Cardiac Rehabilitation on telomerase activity and the telomere length in T lymphocytes.
شكرا يعطيك العافية. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. في البداية أود استغلال الفرصة لأقدم يعني شكري وثنائي للجنة العلمية واللجنة المنظمة وعلى رأسهم الدكتور عبد الله الشنقيطي على حفاوة الترحيب والاستقبال وعلى التنظيم والتنسيق لهذا المؤتمر، وأسأل الله التوفيق للجميع سواء اللجنة المنظمة والعلمية أو الإخوان والزملاء المشاركين في المؤتمر. My topic today is about the effects of cardiac rehabilitation and on telomerase activity and telomere length in T lymphocytes. This study was conducted on myocardial infarction patient, and I try to find the effect of cardiac rehabilitation, which is the physical therapy program, on the myocardial infarction patient, and find the effect of this exercise on the lymphocytes, the telomerase activity, and telomere length. First of all, what's the myocardial infarction? As what we can see here, it is myocardial infarction. There is a part of heart muscles die. Why? Because these muscles not reach enough blood supply to supply these muscles. Then these muscles is die. Secondary, the plaque that build up in the artery. This plaque build up in this artery maybe make the artery narrowing, or make the artery it's complete closed. Then this start to build up the clot of the artery. This clot or this narrowing or this stopping the blood supply, usually it is start from atherosclerosis or from inflammation. In fact, there is a big debate between the scientists about who's the first, who's the consider about the other. Atherosclerosis is lead to inflammation, or inflammation is lead to the atherosclerosis. It is like the story of chicken or egg. But in the fact, the inflammation, it's lead the atherosclerosis. Atherosclerosis also it's lead to the inflammation. There was an overlapping network of pathway in the mechanisms of inflammation and atherosclerosis. Both of them lead to the high risk of death. Okay, now the myocardial infarction, it's happened. And we want to know what's the response of the immune system on the site of inflammation or atherosclerosis. The immune response, it is started by regulated by T cells to become recruited to the inflammation area. As we know, the white blood cells is the cells take responsible to protect our body against any bacterial or virus that engulf our body. In leukocytes, we have mononuclear cells and granulocytes. In mononuclear cells, I choose the lymphocytes to do my study. In lymphocytes, there is a sub-unit, B cells and T cells and natural killer cells. I choose T cells to do my research. As you see here, there is a sub-unit also under the T cells, CD4 helper cells and CD8 cytotoxic cells, double positive T cells and double negative T cells. These cells, it is from, as you know, there is adaptive immune system and innate immune system. T cells, it is from the adaptive immunity system. T cells originate in the bone marrow, then travel during the bloodstream to the growth, to the thymus gland to complete the growth process. From here, these cells take her name from thymus, T cells. Okay, T cells, it is cell. Any cells in our body contain nucleus. Each nucleus in our body contain chromosome. Each chromosome contains the DNA. What is the DNA? Deoxyribonucleic acid is molecule that contains the instructions an organism needs to develop life and reproduce new cells, new generation. These instructions are found inside every cell and are passed down from parents to their children. Okay, now we know there is a chromosome. The chromosome inside the nucleus inside the cells. These cells, it's called T cells. T cells come from the immune system. The chromosome, you see here, there is 4 arms for each chromosome. Each arm ends with red color. The red color, it's called telomere. What is the telomere? Telomere cap the end of linear chromosome and are needed for successful cell division, for proliferation and make new cells. What's the function of telomere? Telomere, the main function for the telomere to protect the end of the chromosome, also to prevent the fusion that may occur between the 2 chromosomes, also facilitate complete replication of the end of linear DNA molecule. Okay, as you see here, there is a telomere in the chromosome of adult cell. This telomere, it is responsible for division, to make a new cells. This cells in each subdivision, in each division or proliferation of cells, this telomere, it become shorter and shorter. The telomere end with senescence, شيخوخة التليموريز. And this senescence of telomere will be lead to die of the cells. If the cells die, that means the tissue will die, then the organ, then the human will die. What does this mean for physical therapist? From this point, I make my aim to identify the effect of cardiac physical therapy rehabilitation on telomere length and telomerase activity in patient diagnosed with acute myocardial infarction. The hypothesis for this study, it was the effect of cardiac exercise rehabilitation might be co-dependent on telomerase and immune system. The methodology, the ethical approval were obtained from NHS in the United Kingdom. The consent for also taken from the patient. Inclusion criteria, it was patient must over than 50 years old. Also, the patient must be diagnosed as myocardial infarction, and also the patient must be undergoing for percutaneous coronary intervention. Patient must have samples taken within 24 hours after the catheterization and also after the 3 months of cardiac rehabilitation. Exclusion criteria was we exclude any patient suffering or diagnosed immunological dysfunction or hemodynamic instability, cardiogenic shock, and unconsciousness. Also, any other study involving investigatory drug within 30 days period of this study, or the patient incapacity to consent verbally. The cardiac rehabilitation program in the United Kingdom, by the regulation of NHS, all patients must undergo the physical rehabilitation after the cardiac surgery, any type of cardiac surgery. Also, in according with NHS regulation, this patient underwent cardiac rehabilitation 1 week after myocardial infarction. In this study, we accepted any type of aerobic exercise as cardiac rehabilitation, but not as a strengthening exercise. There was variation in aerobic exercise between patients. Also, there was variation in location, and this location, the place of the patient, different from patient to patient, and depending on where they live. The main goal here was to discover whether aerobic cardiac rehabilitation for 3 months had an effect on telomerase activity, telomere length, and lymphocytes, immune system, regardless of the type of aerobic exercise, regardless the duration of session, regardless the location, the place of the exercise, regardless the medical team who care for and observe the patient, but must be each patient under supervision of medical team and physical therapy rehabilitation. The primary aim was to find out the potential benefits and the changes in clinical condition after cardiac exercise rehabilitation versus before cardiac exercise rehabilitation. The parameters, I used the accelerometer and GenaActive software for the analysis of daily activity in patients with myocardial infarction. As you see here in the picture, this is the accelerometer, wrist accelerometer, and in figure B, it is a charger cradle and the computer system. We connected the accelerometer to the charger cradle and connected to the computer. In the figure D, you can see this is the software to set up the accelerometer for each patient. In figure E, this is the software to collect data and analysis this data for each patient. Also, from the peripheral mononuclear cells, we take sample to do the human regulatory T cells quantification, human whole blood true count, telomere length determination in human peripheral blood mononuclear cells. As what you see here, this is the fax machine. This one is fax canton machine to find single, it is work in the single cells and to determine each cells, what's the type of this cells. It is CD4, CD8, double positive, double negative, and differentiated from B cells, mononuclear, and other cells. And here you can see the steps to find out the type and getting exactly what type of cells we need to study it. Okay, the result and discussion. There was no significant change in weight and body mass index between pre and post cardiac rehabilitation for the patient. In acceleration, we mean here the activity that the patient produced. There is a significant change as what we can see here. This is before rehabilitation, and this is the activity done by the patient after cardiac rehabilitation. Also, in time that the patient spent in daily activity, it is improved after cardiac rehabilitation. Also, the daily physical activity significantly increased after cardiac rehabilitation. In this graph, we can see from 0 to 50 here, this the minimum activity that produced by the patient, and also the rest, and also the sleep of the time that patient sleep. It is from 0 to 50 milligalileo. We can see here it is decreased after rehabilitation. That means the patient produced more activity. Also, the minimum activity from 50 to 100, we can see here in this figure, it is increased. Also, the moderate to vigorous activity from 100 and 250 milligalileo, we can see there is significant improved in each category. And this figure here, it is represent the moderate to vigorous activity, daily activity. Okay. There is improvement in the daily activity, the patient more active now. What about the percentage of regulatory T cells? We found the percentage of regulatory T cells significantly decreased after cardiac exercise rehabilitation. We can see here there is we getting the regulatory T cells for 3 levels. This is the highest level and low level, and no expression for regulatory T cells in this level C. All of that, there is a decreased in the percentage of regulatory T cells, and this decrease was significant. Treg, or regulatory T cells, secrete transforming growth factor beta and interleukin 10 and other inhibitory cytokines, which suppress the immune system and also atherosclerosis. Our study showed that regulatory T cells expression significantly decreased with the high and low and no expression of CD25 positive. Based on this, the decline in regulatory T cells after cardiac rehabilitation, it might suggest that there was no inflammation, or at least the inflammation level decreased, which lead to decreased regulatory T cells percentage. Here we can see the absolute number for the whole T lymphocytes and the comparison between pre and post cardiac rehabilitation. In this graph, we can see the absolute number of T cells, the whole T lymphocytes, it was decreased and significantly. All of this study demonstrated that lymphocytes and with subset in lymphocytes significantly increase in peripheral blood after myocardial infarction. And we can see after the rehabilitation, this absolute number is significantly decreased. The relationship between telomere length and telomerase activity in peripheral blood mononuclear cells for myocardial infarction patient with pre and post. Okay, unfortunately, there is no significant, statistically, no significant in telomere length or telomerase activity. But as we can see here in figure B, there is a trend toward positive correlation between telomere length and telomerase activity after the cardiac rehabilitation. This study found a positive correlation between telomere length and telomerase activity. Patient exhibiting low telomerase activity also exhibited shorter telomeres, whilst patient whose telomerase activity was medium or high exhibited ability to maintain or even extend their telomerase. Many studies provide evidence of a positive link between exercise and telomerase activity and telomere length. It has been suggested that low telomerase level in leukocytes and therefore shortened telomere may be a predictor of cardiovascular disease. This study also finds there is a significant correlation or significant effect on cardiac physical exercise, increased telomerase activity and telomere length. For the conclusion, in this study, after 3 months of cardiac physical therapy rehabilitation program, the daily physical activity significantly improved. Also in this study were no significant changes in body weight or body mass index after cardiac rehabilitation compared to the pre-cardiac rehabilitation. Cardiac physical therapy exercise lead to significantly reduced the regulatory T cells percentage. Also, therefore, positive correlation. This is the limitations on this study, and many thanks for your attention.
Thank you, Dr. Naif, for your interesting presentation.
بسم الله الرحمن الرحيم. بداية بنشكر الأستاذ الدكتور عبد الله الشنقيطي لحفاوة الترحيب والاستقبال والإقامة وكل شيء كان بوزيتيف بالنسبة لينا كلنا يعني. وطبعا بنشكر الدكتور صلاح والدكتور مصطفى. Our next speaker is Prof. Dr. Faisal البقمي. He is a chair of public health and assistant professor, Department of Physical Therapy. Imam Abdul Rahman bin Faisal University, College of Applied Medical Science. Saudi Arabia. He holds PhD, Community School of Medicine, Faculty of Graduate Studies, University of Calgary, Canada. He holds Master of Science, School of Medical Rehabilitation, Faculty of Graduate Studies, University of Manitoba, Canada. His lecture title is Rehabilitation Robotics, The Way Forward. I hope to be in time, Doctor, 20 minutes.
Okay, I'll promise to keep my time. I would like first to thank the organizing committee, and I would like to thank Dr. Abdullah Shinqiti for putting this conference together. And I would like to thank the audience. Nobody thanks the audience. I would like to thank the audience for their patience with us. 3 days of people talking, I know it takes a lot, but I'll try to make my lecture fun, interesting, as much as I can. So I know it's almost forward. So I want to talk about rehabilitation robotics. And before we talk about rehabilitation robotics, we just want to look what is the global trend, what is happening globally. And this is actually the global trend of what is happening in the world. We know the world population is growing drastically. By 2030, we'll be at 8 billion. By 2050, we'll be at 6 billion. The most interesting thing is we see the aging population is increasing globally, and this includes Saudi Arabia. We have a baby boom about in the 50s or 60s, and these people are going to go older. And when we approach 2030 with the vision, we have an aging population. And with the aging population comes also the strokes, or stroke survivors. And the stroke survivors, we see the numbers of stroke survivors. Because of our advances in medicine, recently we see there's a lot, the survival rate of strokes are higher. That's a good thing from a survival point of view, but it will put a strain on the rehabilitation system that have been designed by the healthcare system. Now, there's an increase also in neurological conditions. And this is also happening globally. We're talking globally now. There's about 1 billion people that are suffering or diagnosed with some neurological condition, and about 6.8 billion annual deaths. And this is globally. These numbers are big and huge. Now we talk about money, which is every nation in the world now is struggling with their healthcare system. The healthcare system globally has been increasing the burden on governments of the expenditure, and we see that Saudi Arabia is no exception at that. We see it in Europe, we see it in a lot of places, and we can see here what the actual cost per person is. For example, if you look, the most interesting thing is they have they classified as 2 types of strokes, but if you put them together, you'll see that strokes actually takes the lion's share. About 26 billion and 36 billion, and we talk in euros here, by the way. It's not reals, it's euros. So it's serious money. And also dementia, which is about 105 billion. And this is statistics from the Institute of Rehabilitation Robotics, or Advanced Rehabilitation Robotics, which is a European institute. And these numbers are how much the EU is going to spend. The Arab world, the numbers are not there. We don't have the statistics for it, unfortunately, but hopefully one day we will have it. Now, the neurological conditions, the burden of neurological condition, unfortunately, is not calculated in Saudi Arabia or the Middle East in general, but in Saudi Arabia, and we need to do that. But just to give you a glimpse of what's happening, because European kind of more or less will have the same healthcare system that is going on there. So it cost the European Union about 798 billion euro per year. And most of these on healthcare, which is therapy. Therapy represents 23% of all expenditure of that money goes to therapy or rehabilitation. Now, let's go to actual therapy, actual stroke patient therapy. If we look, and this study was done in good hospitals with good rehabilitation programs in the European Union. So they only chose the best hospitals in the European Union, and they looked at the rehabilitation of stroke patients. And what they found out is therapy represents a small amount of the daily time spent with the patient. Most of the time the patient is being spent in the hospital is idling. The patient is either sleeping, sitting, doing nothing. There's no therapy because the therapy amount of time it represents about an hour or 2 hours. And we are talking about top tier hospitals, the hospital with the most advanced, in Europe, most advanced rehabilitation programs out there. So you can see that there is a lot of time that the patient wastes doing nothing, sitting around. And that costs money, that costs a burden in the healthcare system. Now, let's move on. And this is from Cochrane Library. And what they did, they looked at evidence of new technology. And if you look at the graph, there is a huge amount of new evidence, a more clinical evidence-based literature, that there are new technologies coming in. There is a new innovation in healthcare. There is a new way, there's a new wave coming out. As you see it in the 1990s, 1999, the new technology emerging is small. But with the advancing of processing power for chips and computers, we can actually now start innovating new technology to deal with the burden of healthcare. So what is the trends in healthcare? So what we end up with here is a trend where the demographic is changing globally. There's more demand. There's an increase of neurological conditions. All that will be the stress will be put on the therapist. So the amount of therapists needed to do the work, we see that there is a rise of need of rehabilitation professionals. Also, there is an increase in healthcare. And this is happening globally and happening especially in Saudi Arabia. With the Vision 2030, all of you know that the healthcare system in Saudi Arabia is going through an overhaul. And this overhaul main objective is to decrease the burden, the economic burden on the kingdom. Because our healthcare costs us a lot and we need to mitigate that cost. Okay, and so we go, also there is an evidence of, clinical evidence of motor learning. There is a lot of evidence coming out that there is motor learning, and that will increase the efficiency of use of advanced technology. So through that model, through that trend, we can see, we can move on to the next thing, which is the medtech industry worldwide. So you can see the world medtech industry in Asia, for example, it's about $71 billion industry. In North America, it's 134 billion. And Latin America, 20 billion. And Europe is about 100 billion. If you can see there, the Middle East is missing for medtech industry. This is the industry of the future for healthcare. It's not pharmaceuticals. It's not building hospitals. It's not training more doctors. This is the industry of the future. This is the industry that will either support the healthcare system. This is the industry that will make the country, will make the healthcare system for the country a net positive for their budgets, not a net negative for their budgets. So your healthcare system actually makes money, doesn't lose you money, okay? And that's what we see. For Europe, it's $100 billion yearly. In the highest is North America, which is 6.4. And in Asia, which is 71, that's in 3 years, by the way. Within 3 years, their industry growth was $71 billion. That's what we're seeing now. So let's talk about the global robotic market outlook. And this robotic market, the global sales of robotic markets increased 26-fold. This is just between 2008 to 2018, and now it's an $85 billion market. The rehabilitation robotics in it growth significantly from just about above 600 million in 2018 to expected growth is 6.4 billion in 2025. And this is global sales, the market outlook. The job market, which I think Dr. Samir was talking about the job market. Like there's a lot of physiotherapists coming out and we don't have jobs for them. What do we do? And that's what it is. University of Taiba is an educational institution and they're graduating their students. So the job market, we can see that most of the jobs in robotic rehabilitation or robotics is actually in the healthcare sector. There is a huge demand for robotic skills in the future for new graduates, where there's a huge demand for robotic skill. There is an increase 13%, and this is according to the EU, the latest EU report, that there is a 13% increase in the demand of robotic professionals with robotic licensing. People who can actually use these machines, not buy them and put them in a clinic and nobody knows how to use them. The bulk of hiring was in the robotic sector. So the rehabilitation robotic is not just treating the patient. It's a whole industry. There's a whole industry behind it. There's an industry, there's a training. As a healthcare professionals, you're the one who understands mainly the rehabilitation of the patient. But also, if you can understand the robotics within it, you can combine two, which is the industry itself and providing a healthcare system. Okay. Oh yeah. So what is the proposed application for these robotics, these rehabilitation robotics? The proposed application was now, what is happening now on the scene is the exercise training devices for stroke patients, whether it's our lower limb or upper limb. Wearable power braces for daily use. And these are the as they say, the holy grail of whoever can achieve a wearable power braces for daily use. And by the way, that picture is in Japan. That's an exoskeleton in Japan, which is a prototype actually, which is a system for daily living for people with disability. And this is the main goal, the end result of robotic rehabilitation. Also, social or telepresence robot, and one of the people that are leading the field in this is the Japanese government actually is allocating a huge budget for telepresence, or social robots, they call them. Because of the aging population in Japan, is about 80% of the population is above 60 now. Okay, so what is the proposed saving? Why are we doing this robotic rehabilitation? Well, it's labor saving. The most important thing of robotics, it delivers the same therapy with fewer staff. Delivers more therapy without increasing the staff. Without increasing your staff, you can deliver more therapy. Cost of personal training for the cost of technology is falling. Now, the difference is when you talk about robotics, especially on a healthcare system perspective, training medical professionals is expensive. It's increasing in expense. Where technology, we can see that we can see the prices are going down, the expenses of making them are going down. For now, they're more expensive than training people, but within 3-4 years' time, they will be cheaper than actually training people. Okay? The model of rehabilitation now, all the models that you saw in rehabilitation, the main model of rehabilitation is one-on-one model. What does that mean? It means that a therapist will be with the patient, a therapist treats the patient, and it goes on. So the time of the therapist is spent with one patient at a time. And that is labor. It consumes a lot of labor, consumes a lot of energy, and it consumes a lot of cost for the healthcare system. So the robotic gym. Now, there is a way of doing this. I think somebody before me was talking about robotic gyms. You saw them. Now, robotic gyms, the idea was to make it 2 to 5 or 2 to 6, meaning 2 therapists will be there. We'll have 5 robotic stations, which will do different types of rehabilitation, and that will result on 2 to 5, which saves a lot of cost for it. However, it is not the end result. This is seen by a lot of experts as the halfway between the two. What it actually, the idea behind it is to move toward a completely autonomous rehabilitation process. And we'll get to that, inshallah. Okay, what is the economic barriers of this robotic rehabilitation? The economic barrier, the cost of the devices are high. Useful life is short. So I would actually caution against, for medical institutions for now, to actually calculate the cost, because it is good to have some robotic rehabilitation, but they are expensive, incredibly expensive to buy right now. And their short life is short because within the industry is growing. So we can see within 2-3 years, these devices will be obsolete, something else will come out. The devices consume a lot of space. And as you all know, the most expensive thing in hospital is space. Departments always fight about it. We need a lot of space, especially for the rehabilitation staff. We need a lot of space. These robots are rehabilitation robots. Still, they consume a lot of space, huge amount of space. These robots devices remain highly specialized, limited ability to substitute human therapy, and that is true. Most of these devices were designed mainly now they're designed in behind engineers were designed for a specific type of exercise, a specific type of function, where a therapist can actually do multiple functions if he wants to. And you can buy one device for one function, it will be too expensive for it. Also the complexity of the device, and this is something that we can see here because we don't have the economy to support it, and we don't have the engineering know-how. Buying a device on its own is a complex process because you need to also know how to maintain that device. You need the maintenance for it is really expensive to do it. And it costs more labor. Okay, this is the question that everybody should ask. When you're talking about rehabilitation robotics, and you will meet a lot of people from companies that will visit you in Saudi Arabia here, and they will have their robots, they want to show it to you, and they want to tell you, you need to ask yourself as a clinician, can robot provide effective therapy than humans? And that is a legitimate question that research is actually trying to answer now. What we know is robot can do a lot of repetition, and that's what we actually understand now. The most significant thing about robots is they can do a lot of repetition more than a therapist, because a therapist is human. He will have a full load of patients. Let's say you have like 3 stroke patients or 4. At some time he got exhausted. He can't do the same movement over and over again, but a robot can do a huge amount of repetition. And if we know anything about stroke rehabilitation, is repetition is the key, right? Okay. Great time of consistency and potential use. That's the most thing. Most of them simulate actual work. They don't actually do the task. And there's a difference between the two. Okay, there's different type of robotic rehabilitation. Workstation, which is the effector, cable-driven, and wearable exoskeleton. These are the 3 main designs. This one is the what they call a workstation, which they kind of have station and they do the movement. And there's cable-driven, and cable-driven give you more flexibility. The motors at the top, but they're more bulky to use. Here's their lightweight and their advantages and disadvantages. Then there are wearable braces, which is actually beneficial for spinal cord injury patients, and relatively predictable, people with predictable impairment. And there's also wearable power braces, also can control the mechanism, difficulty to balance. They're really complex, and durability and reliability of those devices still unproven. ADL, this is the exoskeleton, lower limb exoskeleton, was actually done now. And this is the acceptance, and this is the most important thing. This is the acceptance of the medical staff to this robotic rehabilitation. Because the last thing you want to do as a department head is to buy some of these robots and your staff doesn't know how to use them, or doesn't accept them, or doesn't see them as reliable. Last minute. Okay? Last thing, I want to talk about Vision 2030 and robotic rehabilitation. His Excellency, the Crown Prince, when he had the 2 cell phone example for people, talked about Vision 2030. And Vision 2030 have two main points, if you want to take it from it. One is it's based on economic transition of the kingdom, meaning saving cost and making the kingdom having a diverse economy, and healthcare can be one of those economy. Second is we're going to use technology to achieve that. And the way to use technology to achieve that is to look to invest in the robotic rehabilitation as an industry. not as consumers, but as an industry, as healthcare professionals. And that is the way rehabilitation, the future of rehabilitation is going. And this is your whole take-home message. I hope you get the message that rehabilitation robotics, it's not only some devices that somebody comes from Europe and sells it to you, it's a whole industry. It is growing, and it will be the future for rehabilitation. If we want to get into it now is the time to do it. Thank you very much.
Thank you, Doctor. Now, I'm inviting everybody here, the speaker, please, for 10-minute or 11-minute discussion. شكرا دكتور، جزاك الله خير. Until our speaker sitting on the chair, I really, since I am from Medina people and I'm working here since 30 years, really I want to thank the Dr. Abdullah and all the team for doing this conference and making the Medina for international conference. And I am not a respiratory therapist, I am a pulmonologist, but I am heading the respiratory therapy in Medina. Really, everybody we don't know. Everybody knows respiratory therapist. It's just for training, and we're sending for respiratory therapist. A lot of people, unfortunately, they do not know what is the important and what is the meaning of respiratory therapy. I was fighting 10 years in Medina just to satisfy the Ministry of Health about respiratory therapy until we satisfy them and we start half a job in the Ministry of Health. Now, as we see, everybody knows respiratory therapy, but he doesn't know there is a branch. Everybody hear about, people to start about from physiotherapy, respiratory therapy. Today, we know there's a cardiac therapy that doing these things. This is a very major and actually very completed in all medical departments, this branch, but actually you are a people, it needs to be more conference, more awareness for the people so that it will be benefit. We need it all really. Thank you, Mr. Abdullah. Now, I'm starting for 10 minutes. Any question, please? Okay, if there's no question, I will ask Dr. Dat about your presentation about non-pharmacological treatment of some chronic disease or acute disease. Actually, I got my chance, I will ask first. That I'm with you and without with you, that because in all the public, they have the chance, we have a problem that maintaining the people about medication, that a lot of people, they are not for chronic medication, that doesn't want to be believed that they are sick, especially the young people, for example, primary hypertension. And this kind of people, they are not complementary with taking the disease. No, we are young, we take it that they need to be chronic medication. So I don't supporting the idea that, for example, and until now, I think that as you presented, the hypothesis is not approved that the primary hypertensive patient can be treated with non-pharmacological. It can be helping, but actually this idea already in the public that we can treat ourselves without medication for chronic disease, except hypertension, this will have the complication. So I think it can be helping, but it's not can treated. I don't know what to give it to you, please.
Thank you so much, Mr. Chairman, but I don't know what is your subspecialty, please.
Pulmonologist.
Actually, we are talking about importance of a change lifestyle, importance of aerobic exercise in preventive measures, and it might be sometimes not only we can't neglect the effectiveness of pharmacology, but physiotherapy, as everybody knows. احنا العلاج الطبيعي اكتشفوه من 200 سنة عشان نبعد عن الكيميكالز توكسيك in form of drugs الأدوية ونبعد عن مضاعفات الجراحة. الهدف ان احنا نبريفنت او على الاقل نتشينج لايف ستايل. لكن واحد عنده هايبرتنشن هياخد علاج بلا شك، لكن ممكن نتغاضى عن هذا العلاج لو احنا ابتدينا في الاول الناس الاوبيز بيشن اللي بندخلهم في برامج توعيه ثقافيه وبنعمل له تشينج لايف ستايل. اول حاجه ريدكشن بودي ويت، تاني حاجه يكيب ايروبيك اكسرسايز، تالت حاجه يمنع مش عارف التدخين، كل بقى الريسك فاكتورز. we can dealing with the hypertension without pharmacological approach, non-pharmacological risk.
Actually, it's not the treatment; it's preventive. You can preventing and supporting it, but just I want to insist we cannot treat it. This message in this conference actually have to be insisted that we can prevent it, because prevention actually this is the major aim.
Preventive is
it's good for prevention, but it's not for treatment. It helps the treatment. Thank you. Any question, please?
Yes, over here.
Yes.
Thanks for all speakers for informative lectures, but my question to Dr. Faisal regarding the robots, I think it's cost a lot. So, is it superior to other modalities used in rehab, like mental training or virtual reality? Because there is other modalities that doesn't cost much, and I'm not sure if it's worth it or not. The robot.
I think I'm biased toward it, so I have to, the disclaimer. I think robotics, for now, there's a lot of research going on it. What I'm looking at is the next 20 years. And I think in the next 20 years, robotics will prove to be the go-to for rehabilitation. The reason why I'm saying that is the main goal of robotics, it's not to treat the patient at the clinic. The main goal of robotics is your patient will come in, you'll do the rehabilitation program, and then he will get the exoskeleton, and then you send him home. And then he will have the rehab process going all day, 24/7. He can put it on. And that's the holy grail of robotics. That's what they're looking for. What I'm talking about now is this is an industry that is growing. This is a trend that is global. This is what's happening. And I always like to compare it with computers, something that you use in every day. If you talk to your father in the 70s about computers, and he's in the 70s, nobody knows anything about it. In the 80s, people start seeing computers as bulky, huge, expensive. We can use paper. It's easier to use paper. But now, the other nations, or Western nations, got ahead of us, and they moved on. Now we're consumers of their products. What I'm encouraging is to people to start looking at rehabilitation robotics as the future, not the present. Because at the present, rehabilitation robotics still it's in infancy. They're still starting. It's just the only place that they can actually prescribe lower limb exoskeleton is in Canada, and they can prescribe it now for patients as kind of a prototype to see what happens. But this is a trend will happen within the next, I'm giving it 10 years. Within 10 years, you'll see that's the name or protocol for it. And all other modalities will kind of subside because this is a superior, because it is consistent. That's what I want to say.
Any more question, please? Yes, please.
My question is for Dr. Samir. First of all, thank you for your nice presentation. Dr. Samir, my question is, you mentioned in your presentation that the aerobic exercise has great effect to prevent the sudden heart attack. And also, same time, you mentioned that the football and basketball player, great amount of people with sudden heart attack. Okay, these people, already they doing aerobic exercise. So what is the reason for this?
I am talking about first, my research is a primitive results when we uncover 30 villages for sustainable development and how to change the bad style and I am talking about first factors related to the importance of aerobic and as well the dangerous if there is any hidden factors related to young athletes, it might go to the end result, death. So I'm just mentioning the fast factors about such importance of athletes or training.
One more question, please. last question.
Assalamu alaikum. Actually, it's not a question. Thank you, Professor Samir, for his great lecture. I'm just want to add something that our cardiac muscle is not like our skeletal muscles. It's a very sensitive muscles. It can work only or mostly aerobically. I mean that you've got to ensure a very good coronary blood and oxygen supply for your muscles. For our friend, he asked about the athletic person, that we forget some of the athletic person think that they still can perform very stressful exercise and they are away from cardiac death. We still, a human being, if you are highly athletic, you still need to know that your cardiac muscle cannot stand severe and vigorous and sudden stresses during the exercise. And also I want to add that one of the most common risk factor now for coronary artery disease is stress. It's not cigarette smoking now or obesity or hypertension, but we putting ourselves in a severe stress, especially the young person. So if you are sleeping in your bed and you start thinking all the time about your work, your life, your future, you're putting yourself under severe stress and you are exerting your heart very much. Thanks.
So more happy, more healthy.
Dr. Mr. Chairman, if you please, I have a
you.
question.
Now-
I have a question, last question, please, to my respected brother, Dr. Faisal. By the way, Dr. Faisal is first batch graduate from King Faisal University before. This is my student, and I am very proud with him. يعني أفخر. Dr. Faisal, where are we? احنا فين بقى من robotic technologies just right now as a develop يعني when we compare developed countries, where are we? يعني أنا من 4-5 سنين كان 2 روبوتس موجودين في الميدل ايست، يمكن في المملكة في 2-3 لوكومات. ف where are we right now, Dr. Faisal?
Where are we now? It depends. That question depends. If you're talking about consumers, I see a lot of companies coming from Europe, coming from the States, trying to sell their new inventions to us, which will be obsolete in 3 years. And it will have also maintenance issues. As an industry, we still don't have it. It's not even established. My advice, if you're going to approach one of these companies or the department head to buy, make sure that you have a trained personnel for it. Don't let them sell it for you and don't have the license to operate it or know what's going on with it. Because most of these companies will sell it, unfortunately, and the athletes, that's why I showed the slide before the last, was the model of how physical therapists interact with new technology, because some physical therapists will actually reject this technology as not their way of doing things. So that's as an industry, we still don't have it yet. Thank you.
Thank you, everybody. Just now, I'm inviting Dr. Faisal. Dr. Samir. Dr. Hajid. Dr. Daif. Thank you for our speaker, really, for selective and pioneer speaker. Really, thank you very much. Thank you.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. Today we welcome Dr. Hamada Ahmed Hamada in our international conference. Dr. Hamada is a lecturer of biomechanics and kinesiology and ergometrics in Faculty of Physical Therapy, Cairo University, a lecturer of biostatistics at اليوم University. He worked as a lecturer of mechatronics at the Faculty of Engineering in Shams University. He published more than 40 articles, ResearchGate Index 14, Schoolbooks Index 2, ISI Index 2. He works as chief editor in World Journal of Sports Science. He works as regional editor in many journals, like World Journals of Medical Science, European Journal of Applied Science. He works also as a reviewer in many journals, as British Medical Journal Open Journal, Journal of Clinical and Analytic Medicine, American Journal of Physical Medicine, Journal of Acta Clinic, Croatia, Journal of Back and Musculoskeletal Rehabilitation. Also, he works as a consultant of sports injury and spine rehabilitation in Physics Center in Egypt. His lecture today under the title of Shoulder Impingement, Biomechanical Consideration in Rehabilitation. You can go, Dr. Hamada.
بسم الله والصلاة والسلام على رسول الله. Before I initiate my presentation, I asked all the audience to stand up 5 seconds to release or to change their body, because the prolonged sitting is a predisposing factor for musculoskeletal disorder. Please stand up 5 seconds to change your position, to be made concentrate. Thank you for accept my request. Nowadays, we will talk about shoulder impingement syndrome, biomechanical consideration. Our objective, we will talk about the types of the shoulder impingement syndrome, prognosis, biomechanical and neurophysiological cause, and our consideration. Our types of shoulder impingement syndrome. There are several types of shoulder impingement syndrome. First of all, we subcricoid impingement syndrome, anterior superior glenohumeral impingement syndrome, posterior superior glenohumeral impingement syndrome, suprascapular nerve impingement syndrome, and subacromion impingement syndrome. We will talk about the subacromion impingement syndrome, the pathomechanics of subacromion impingement syndrome. You have two mechanisms to occur subacromion impingement syndrome. First one, the head of the humerus may be superior migrate and anterior translate. So the head of the humerus approximate from the acromion. The second one, the acromion will be approximate to the head by decrease the upward rotation of the scapula, increase anterior tilt of the scapula, and decrease the external rotation of the scapula. I will ask the audience about the prognosis of shoulder problem. Good prognosis or poor prognosis, and why? The shoulder impingement syndrome, poor prognosis. Biostatistics reported that 41 to 55% of patients reported symptoms of shoulder impingement syndrome after 1 year from initial assessment and intervention. Do you imagine why? Why this poor prognosis? Maybe relative unsuccessful treatment or intervention, yes. You have two factors. The first one, the true factor that cause the impingement syndrome is not addressed because we think about the body as biomechanics only. No. The body, there are two mechanisms to be or to obtain equilibrium. There are biomechanical factors which will be integrated with the neurophysiological factor to achieve optimal function. If there are deficits of the biomechanical factors or neurophysiological factors, there are allostatic protective mechanisms. Allostatic protective mechanisms, you will deal with this. If you deal with allostatic protective mechanism only without knowing the true factor, you will return the normal biomechanics temporarily. After short period of time, the problem will occur again. Or you have a true factor, but the intervention not based on biomechanical principle. We speak in this presentation with only biomechanical factors. Biomechanical factors, two items is very essential to know. The problem may be regional, related to the area, or the problem may be regional interdependence. Regional interdependence meaning what? Unrelated region may be associated and maybe cause the problem in another area. A regional factor, we will speak about 3 factors only. And in each factor, we will speak about one example only. Maybe a glenohumeral muscle imbalance. We know that there are couple force between the deltoid and supraspinatus and the infraspinatus, rotator cuff. The deltoid will be superior migrate the head. The supraspinatus medialize the head. Infraspinatus serum minor will be inferior glide the head. Okay, if there are deficits in this mechanism, which lead to impingement syndrome. If the rotator cuff, mainly infraspinatus serus minor, is weak, we can't make inferior glide to the head. So the head will be superior migrate and then translate and make impingement syndrome. On biomechanical consideration, if you know that you want tensing the infraspinatus muscle, what do we do? If you make this exercise by shoulder abduction, 45, and ask the patient to make external rotation. By this, you will increase the strength of the infraspinatus, but you will observe that we will increase the activity of the upper trapezius, which will lead to imbalance in the scapulohumeral muscle. Yes, you will concentrate on both. ما تصلحش حاجة وتبوظ حاجة. So, when you make this exercise, you instruct the patient to make scapular retraction and ipsilateral rotation of the trunk. This will increase the activity of the middle trapezius. Why? Middle trapezius will be increased. Increasing the middle trapezius and the retractor will increase the activity of the rotator cuff by 24%. Yes, and will decrease the activity of the upper trap. One example to dynamic control ratio, DCR, is the ratio between the eccentric mode of the external rotator to the concentric mode of the internal rotation. This ratio must be more than 1. If this ratio below 1, you have risk factor to impingement syndrome. You should be increase the strengthening eccentric mode of the lateral rotator. Scapulohumeral muscle imbalance. There are force couple between upper trap, lower trap, serratus anterior. This force couple will make upward rotation of the scapula. If there are imbalance here may be in activity. Imbalance here may be in timing. In activity, I need contraction of the serratus anterior, 40% of the MVI, maximum voluntary isometric contraction. In this case, If the serratus anterior weak, lower trap weak, lower trapezius weak, and increase the activity of the upper trapezius will lead to impaired forcible and impingement syndrome. One example of have lower activity في trapezius. Lower trapezius لو activity بتاعتها قلت decrease, we will strengthen it by this position. Yeah, if you observe this position will increase the lower trapezius. But you will observe in this position also will increase the upper activity by 33%. So you will impair the forcible. You will make scapular retraction and the ipsilateral rotation of the trunk to increase the lower trapezius and decrease the upper trapezius. The onset of time. First, when you make abduction, you need the upper trap will be contract first before the motion by 270. Then the serratus anterior will contract, the last contract lower trapezius. If the sequence impaired will lead to impingement syndrome. One example of the sequence delayed is serratus anterior, and we will concentrate in your rehabilitation for recruitment, the serratus anterior, ear recruitment. What you do? You should observe. The scapula should be retracted. If you want to early activation of serratus anterior, the scapula position should be retracted. And the exercise should be below the shoulder level. A closed chain, make early activation. Open chain, not make early activation. Like inferior glide exercise and loro exercise. A scapulo-clavicular couple. All of us know the scapulohumeral raise. No. I speak about the clavicle, which is neglected in our rehabilitation. The couple force, or couple motion, as if when the clavicle is elevated 9 degrees, the scapula will be anterior tilt 6 degrees and upward rotated 3 degrees. And if the clavicle posterior rotation 30 degrees, the scapula will be upward rotation 20 degrees and posterior tilt 10 degrees. And if the clavicle is retracted 1 degree, the scapula will be external rotation 1 degree.
Dr. Hamada, 5 minutes. Still 5 minutes.
Yes. If you have shortening for the subclavius muscle, shortening, will we change the acromion, clavicle? Will press the clavicle downward and makes the clavicle forward, so the acromion will take forward. The humeral head will be retrovergent. The retrovergent make anterior translation. Shortening, ندخل على الريجونال. الريجونال interdependent. يعني كان problem in region away from the shoulder can be affected the shoulder. One example, the position of the head. في forward head posture, if you had forward head posture, a G2, improper posture, we will make impingement syndrome. How? The forward head posture will increase the length of the levator scapulae. The levator scapulae, downward rotation, make downward rotation of the scapula. So, to avoid downward rotation, the activity of the upper trapezius and the lower trapezius will be increased. In this case only, the lower trapezius will be increased in shoulder impingement syndrome if you have forward head posture. So, if you have forward head posture and impingement syndrome, you don't need to strengthen the lower trap. You need to deactivate the lower trapezius, deactivate the upper trapezius. But before done this, you will deactivate the levator scapula. Elevator scapulae can be done by parafunctional habit. بروكسيزم اللي بيجز على اسنانه ما ياخدش باله يعمل له امبنجمنت سندروم؟ يس. واحد تاني دايما بياكل بمين؟ بشفته، بالمنتالز، يعمل له امبنجمنت سندروم؟ اه يعمل له. ازاي؟ ايه علاقتها؟ كل واحد فينا قاعد كده يفكر انا هستاذن الدكتور عبد الله اخد 5 لان انا اتظلمت في الموضوع ده يا دكتور. لا هي انا اصلي 20 دقيقه المفروض استاذن 5 تاني لانه عملوا له ريبليس المحاضره مرتين. حقي. خلاص؟ طيب المنتالز لما يجي كل واحد انا اسال سؤال، كل واحد فيكم هو قاعد يشوف وضع لسانه فين؟ وضع لسانك وانت وقاعد وقافل بقك. شوف لي لسانك فين؟ لو لسانك التب اوف ذا تانج في الابر تيث والباك اوف ذا تانج and the root of the tongue touch the soft palate, you are proper oral butcher like muscle or butcheral. yes في oral butcher وضع لسانك. some person can when eating have tongue thrust طلع لسانه او ياكل بالمنتالز. when makes this will decrease the activity of the suprahyoid muscle. The suprahyoid muscle is neck flexor, deep neck flexor. The antagonist of the suprahyoid muscle is the suboccipital muscle, which is make forward head posture due to high activity. So, if you have OMD, not TMD, all of us know TMD, temporomandibular disorder. No, I speak about the orofacial myofunctional disorder. You will make not forward head posture only. Yes? بروكسيزم اللي بيجز على اسنانه اخر دقيقه اخر دقيقتين. الفورورد هيد بوتشر البروكسيزم لو جالك واحد عنده مشكله في الشولدر وانت عايز ابدا من فوق من الاو من التي ام جي او الاو ام دي ولا ابدا على الشولدر، اعمل ايه؟ اقيس حاجه اسمها الفورس بايت. الجز خليه جهاز بيقيس هنا وبيقيس هنا. اجيب حاجه اسمها الاسيمتريكال اندكس. اجيب الفورس بتاعت الدومينانت ناقص الفورس بتاعت النون دومينانت واقسمها على الفورس بتاعت الدومينانت واضربها في 100. لو لقيت النسبه دي 10 ابدا اشتغل له على المسيتر. اكتر من 10 اشتغل له على الترابيزيوس. اخر حاجه هقولها وهفنش خالص وانا اسف. كله ده مش مشكله. For ladies. This for ladies. The breast shoulder interaction. The weight of the breast can make shoulder impingement syndrome. Yes. The normal size 750 ل 1000 جرام. لو زاد السي او جي هيتحرك لقدام. يعمل كايفوزيس، يعمل ارثوجينيك انهبيشن لللور ترابيزيوس. So the heavy weight او heavy breast will make shoulder impingement syndrome. The last one, the breast size. Breast size. Breast size it is the size. بقيس حاجتين، الباند سايز والباست سايز. الباند سايز and the breast بقيس لو طلع odd number اضيف له 5، لو طلع even number اضيف له 4. واجيب الباست سايز اللي هو at the level of nipple واطرحهم من بعض. ده يديك بالظبط ايه؟ البريست سايز. المشكله في البريست سايز وده الفاشن اللي مش صح، تيجي تلبس برا اليفيتور برا. لما تيجي تلبس اليفيتور برا عشان السايز بتاعها، لان محدش يوم بيشوف السايز، محدش يروح يقول له كاستم برا، لا في كاستم برا. ايه اللي بيحصل؟ ان الاستراب بتاعت البرا البوستيريور ستراب make as a ball system. You will take the breast weight and بيرميه على مين؟ على السكابولا. make scapular depression syndrome and lead to impingement syndrome. Thank you.
شكرا جزيلا دكتور حمادة for your scientific content and interesting talk. Now we will shift to Dr. Khalid خالد الجهني. دكتور كاظم.
Bismillah ar-Rahman ar-Rahim. I would like to introduce our next speaker in person of Dr. Khalid Al-Juhani. Dr. Khalid Al-Juhani is the current Dean of the Faculty of Nursing. He's also the head of Community Health Nursing Department and an assistant professor from the Faculty of Nursing at Taiba University. He holds a PhD from Australia, Carleton University of Technology. He also did his master's in advanced nursing practice from University of Melbourne in Australia. He holds a bachelor's degree from Victoria University of Technology in nursing as well. The title of his lecture is The Role of Rehabilitation Nursing. You're welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. We'll go back to human beings. We've been talking about physics and how to take care of some things related to the body, but now we'll go back to people as a human. All of us as a team members, either from medicine, physiotherapy, or nursing, or whatever the specialty or subspecialty, our main aim and goal and mission in life is to take care of people as a human being. Therefore, we'll go back now in a few minutes. Inshallah, it will be less than the expected time, so we'll compensate for those. So today I'm going to just give some information about rehabilitation or the role of nursing rehabilitation. It's already a subspecialty, or we could say it's a subspecialties. Nowadays in Saudi Arabia, there is a lot of development in this area, especially in cardiology and pulmonology too, and also in some medical sciences or subspecialties, as some people prefer to say. So our aim to introduce the role of rehabilitation and to highlight those areas of development here in Saudi Arabia. So we'll start with the definition related to nursing. So it's a philosophy of practice. We go back to the main issue. It's a philosophy of a practice. From philosophy, the science or the application may develop into different directions. We may say this is a nursing specialty. We may say this is a physiotherapy specialty. There is some overlaps between, but in this lecture, brief lecture, we'll just highlight the development in nursing, just to highlight the point. So rehabilitation is a philosophy of practice and an attitude toward caring for people or for people. And this is what differentiates nursing from other specialties. We care about people and their families with disabilities and chronic health problems. The goal of rehabilitation is to restore mental and physical abilities which is lost. We will give an examples here. So rehabilitation is huge. When we talk about rehabilitation in the coming slides, we will see the different directions that shows us where every specialty is heading to. So rehabilitation nursing, I'm talking about rehabilitation nursing as a subspecialty. The diagnosis and treatment of human response of individual groups to actual or potential problems related to altered function, ability, and lifestyle. Here is the history started with rehabilitation. Florence Slight Angle and Isabel Hampton, who started with some sort of prevention as well as during the Crimean War, how to help soldiers to retain their normal lives. From that point, the progress started with Isabel Hampton and ended up, or let's say the real start with the Association of Rehabilitation Nurses. I'm talking about America, not in Saudi Arabia, established in 1974. So from that time till today, there is a periodic publications and conferences and development in the specialty of rehabilitation nursing. We hope during this maybe 3 to 5 years to attract a lot of them here, especially in cardiology. And it's already started in some cardiology centers in Saudi Arabia. The Harvard Journal in 1975 and 84, the association started there. Here's the wheel we are talking about. The main issues here. We are talking about nursing. Just to remind you again, we are talking about nursing and with subspecialty rehabilitation, not rehabilitation as a science. Promotion of successful living, leadership, interprofessional care, and nurse-led interventions. We mainly focus on a promotion of successful living, and we will go through the next slide with examples and more description of what we mean by each direction here. This is the professional role. This is the nursing professional roles within the healthcare system to the patients and their families. And by the way, we could mention that rehabilitation be applied to a community, not only for the patients or the family members within the nursing scope practice. So the first domain was nurse-led interventions, and in brief, supportive technology to improve quality of life, implementing nursing and interprofessional intervention based on best evidence, provide client and caregiver education in relation to disabilities, chronic illnesses, and health management. And client and family-centered care. It's a huge concept. We couldn't cover it in one lecture or in one day because it encompasses the entire healthcare system delivery models. But we are talking like, for example, stroke patients and the role of nursing rehabilitations. This overlaps with home nursing for those who was exposed to this specialty. Home nursing, one of their roles is to go to patients' home and to do the rehabilitation process either for the patient and his family too. So we are talking about the patients, the close circle of support of people, and even the broader community to obtain maximum acquirement of the rehabilitation process. Here is just a picture of how to do the rehabilitation for stroke patients. Many of those patients stay for a good time within the hospital or hospital care, so they will be under the direct supervision of nursing. So that's why the nurses' rehabilitation interlap with the home nursing duties. In addition, in cardiac rehabilitation, which is a huge science, and the voice raised nowadays, maybe 1.5 years ago, from the Saudi Commission for Health Specialties and other stakeholders in Saudi Arabia, that we need to develop further intervention to cardiac patients. It's not only about taking care for them within the health cardiac center. We have to extend our services. So in this case, home nursing is not the proper intervention to this group of patients. That's why they started the cardiac rehabilitation, was the nurses taking care of teaching the patient and supporting the patient and his family to regular exercise, adapt heart, healthy diet, reduce stress by using the techniques, stop smoking, medical therapy. So here we're talking about medical and psychological social interventions. It's not only just a rehabilitation as a skill or as a science. Domain 2, promotion of health, successful living, promote health and prevent disabilities, foster self-management, promote and facilitate safe and effective care transitions. I would foster more on self-management, which is the most important concept nowadays. It's the #1 important concept, whatever the diagnosis is self-management. It's a huge realms, and there are a lot of inputs, especially from medicine in this science, and those inputs from medicine guiding nursing practice and how to implement self-management. Also, there is social cognitive theories, there is boundary theories, which interrelated to, there are a lot of psychological theories we implement within self-management. I will just give you a brief example here when we talk about this sort of rehabilitation. It's easy to go for hypertension patients in medical science and say, okay, this is your medication, goodbye. The next step, you will do the same. For diabetes patients, it's the same. This is not the issue and not the expected role of healthcare practitioners or specialists, either physicians, nurses, physiotherapists, whatever. Your role is to help the patient, and the patient is the decision makers. It's not yours. He could choose whatever he wants. But within self-management, you have to support the patient with the information and with the change management and with sciences, with theory, how to develop, how to improve his health within systemic way. Unfortunately, till date, up to my knowledge as specialized in disease management, there is no evidence-based practice in Saudi Arabia regarding self-management. It's all by trial and errors, and there is a lot of things to be done within the coming years, inshallah. Domain leadership, I wouldn't say a lot about it, but again, self-advocacy. And here is my message to all of my colleagues. Please take care of your patients. Your role as advocate for the patients is outweigh any other roles. Most of our patients, if you talk to them or to their relative or to your friends when they go to hospital, they are not looking for a very good physicians, rather than a human touch and somebody to say good things to them and try to support them, try to be with them. But again and again, just to remind you, it's not your decisions, it's the patient decisions. You offer them whatever you want, but by then you are not his parents. Paternalistic approach is no more needed in healthcare system.
You have 5 more minutes.
I'm done already, don't worry. Okay, the interprofessional care foster effective interprofessional collaboration, which is the new trends. No one specialty is leading. We are all in the same boat. If one of all of us fail, the entire process will go down. Thank you very much.
Thank you, Dr. Khalid, for restriction to the time. And now,
Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salam ala Rasulillah. Our current speaker now is Dr. Abdullah Al-Shami. He is a leader of pediatric orthopedic rehab program in Sultan City, clinical rehabilitation supervisor, pediatric specialty program, as well as he's a chairman of physiotherapy department in Arabic School for Special Education. Welcome, Dr. Abdullah Al-Shami, and he will speak about the emerging practice of using VR in pain management among children with cerebral palsy. Welcome, Dr. Abdullah.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Good afternoon, everyone. It's a pleasure to be here today with our colleague. First of all, I would like to thank the organizing committee and Dr. Abdullah Al-Shanqiti for the great effort to make this conference successful. Today, I wanted to talk about emerging the practice of using virtual reality glasses to manage a pain experience among cerebral palsy patients, the current state and future direction. Our objective for today, we'll talk briefly about cerebral palsy, pain among cerebral palsy patients, and virtual reality glasses as a modality for pain management. Cerebral palsy, it's a group of permanent but not unchanging disorder of movement or posture and motor function, which are due to non-progressive interference, lesion, or abnormality of the developing immature brain. The prevalence of cerebral palsy worldwide is 2 to 3 cases per 1,000 live births, with a male more than the female. In one of the studies in Saudi Arabia, the incidence of cerebral palsy is 4 per 1,000 patients, 1,000 births. So, over the world, there is a 17 million they are suffering from cerebral palsy. Fact about cerebral palsy: cerebral palsy is the most common motor disability in childhood. The etiology of cerebral palsy is very diverse and multifactorial. The causes are congenital, genetics, inflammatory, infection, anoxic, traumatic, and metabolic. The injury to developing the brain may be prenatal, natal, and postnatal. As much as 75 to 80% of these cases are due to prenatal injury, with less than 10% being due to significant birth trauma or asphyxia. The most important risk factors seem to be prematurity and low birth weight. There is a lot of classification for cerebral palsy. It can be classified based on the motor type. So may classify to spastic with higher percent, 70 to 80%, dyskinetic, ataxic, or mixed. Other classification could be based on the part of the body affected, diplegic, quadriplegic, and hemiplegic. One of the common classification, which is considered like international language of classification for cerebral palsy, is the gross motor function classification, where the patient will be classified based on the functional motor ability to 5 domains. From 1, which is with minimum affected movement, to 5, where the patient will be totally dependent in his mobility. A lot of associated impairment will be result as for cerebral palsy. So 1 over 3 patients, they will be unable to walk. 1 in 4 patients, they will be unable to talk. 3 in 4 patients, they will experience a pain. And this is very important information for healthcare provider. 1 in 4 patients, they will have epilepsy and some other associated movement as well. If we are talking about WHO and international classification of function, cerebral palsy will affect on body structure and function. It will cause a mental function disorder, sensory of function and sensation of the pain, voice and speech, digestive, metabolic, endocrine function, neuromuscular skeletal function, and other physical impairment as well. This physical impairment will reflect on patient activity, limitation, and participation restriction, so that the patient, they will have difficulty in learning ability, general task demand, communication, mobility, self-care, and interpersonal interaction relationship. The prognosis of cerebral palsy, which is considered the most common question from the parent of cerebral palsy patient, 60% of cerebral palsy patients, they will be able to walk without using an aid. 10%, they will walk with an aid. 30% of cerebral palsy patients, they will be wheelchair dependent. The aging factors affecting on cerebral palsy patient who's growing, he will have like more degenerative changes, fatigue, osteopenia because of non-weight bearing, especially in GMFC level 3, 4, and 5, increased body mass index due to physical inactivity, weakness in his muscles, and pain as well. If we are looking for the literature review, talking about the quality of life of cerebral palsy patients, which is were mentioned by our previous colleagues and speaker, that our aim in rehabilitation is to improve his quality of life. So to summarize the quality of life for cerebral palsy patient, we will find pain is indicated as a significant concern in adults with a cerebral palsy. The CP with the limitation of mobility are at risk of lower participation in leisure and recreational activities. The orthopedic condition are the primary challenge in managing cerebral palsy patient, and we will find that the aging process will affect on the quality of life and decrease it. The management for cerebral palsy could be classified to 4 main domains: rehabilitation program, orthopedic intervention, assistive technology, and spasticity management. And as mentioned again by other colleague and speaker, we will work and we will emphasize to work as a teamwork. We work as multidisciplinary and interdisciplinary approach. And for sure, the patient-family center care, where the patient and his family will be engaged in setting the appropriate plan for each patient. This is well-accepted systematic review talking about different intervention in cerebral palsy. They are talking about some technique where recommended, some other technique where they find that is not appropriate or not recommended for cerebral palsy patient. The next part of our presentation, the pain in cerebral palsy patient. As all of us, we know that the definition of the pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. The pain is always subjective. The chronic pain is the most common pain among patients with cerebral palsy. In one of the studies, they find 75% of cerebral palsy patients, they are suffered from chronic pain. And in other literature review, they find that 18 to 56% noting a daily pain occurrence. And again, this is very important data and information for healthcare provider to know the effectiveness of the pain on other area like motor area or any other participation area. The pain was reported in girl more than the boy. The evaluation for pain in cerebral palsy patient is a challenge, particularly if mental impairment exists. Pain in cerebral palsy seem to be overlooked and insufficient treated by caregiver and healthcare provider as well. This is for sure. If we didn't include the pain in our assessment and in our plan, this will be reflecting on the patient in different area negatively. It will affect on the quality of life for that patient. It will be reflect as a fear, an anxiety, frustration, depression. It will affect negatively on social interaction and social activities. So we will find that the patient, most probably he will have like social withdrawal or inability to cope. Educational activity as well will be affected, and sleep disturbance. And I believe in pediatric, that will be reflected as well on the parent as well. If our child, he will have a fever for 1 day, I will not sleep a night to ensure that he's fine. So that physical impairment and the pain will be reflected on the parent, where we need to consider the parent as well in our treatment plan by education, by awareness, and by engaging them in our plan. The common potential contribution for pain in children with a cerebral palsy, just we try to conclude it in a specific schedule. It could be the pain because of the surgical intervention. They will have like a lot of surgery, soft tissue release, selective dorsal rhizotomy, osteotomy, spinal fusion. It could be because of a lot of the procedure they will have it, like administration of anesthesia, blood draw, placement of nasogastric tube. It could be because of the gastrointestinal, like gastroesophageal reflexes, pain or infection, abdominal pain as well. It could be because of the orthopedic complication, like hip subluxation, hip dislocation, alta patella, and others like scoliosis. It could be a result of a neuromuscular, like spasticity, overuse syndrome. It could be because of the rehabilitation as well, and this is very important to share it with colleagues. Rehabilitation, we need to consider sometimes that in some specific intervention, that intervention, it could cause pain for the patient. So just I share with you, like here, a common surgery underwent in Saudi Arabia, the spinal fusion surgery, some procedure like nasogastric procedure or in big tube insertion as well. Literature review showing the correlation between the pain and age. So they will find that as a patient with a cerebral palsy, he will grow. The pain, he will suffer more about the pain. If we will link it for GMFC and the pain, we will find that in ambulant patient, GMFC level 1 and GMFC level 2, most probably they will have a pain in foot, rather than the patient who's like total dependent in his mobility, GMFC level 4 and 5, they will have most probably pain in their hip. Abdominal pain as well, it will be correlated positively with the GMFC level. So the patient who's GMFC level 1, he will have less pain than the one who have GMFC level 5. The American Society of Pain Management recommend a lot of recommendation to be considered within pain assessment. So,
excuse me, 2 or 3 minutes.
Inshallah. Thank you very much. For infant, pre-verbal, and children, they have like specific recommendation. For patient who has like unable to communicate, they have like specific consideration in pain assessment as well as in adult assessment. So this is like valid measurement, like Wong-Baker numeric scale and the FLAG scale, which is wide used in pediatric rehabilitation. The last part of my presentation talking about virtual reality management, pain management and virtual reality. So pain management, it's a multidisciplinary approach. It could be a different approach like surgery, medication, therapy, and non-invasive treatment, and psychological treatment as well. We are focusing to improve quality of life. Virtual reality, as other colleagues they mentioned, recently it was like well utilized in a rehab program. So it's computer technology to create simulated environment. Virtual reality glasses involve head-mounted computer in which user immersed themselves as they could act, perceive, and interact in a three-dimensional world. Virtual reality places the user inside an experience. Instead of viewing like a screen, you will be immersed and interact in a three-dimensional world. So virtual reality, again, it can have like head-mounted display, and it will simulate the vision, hearing, touch, and smell as well. A lot of literature review about virtual reality glasses. We can have it like on PubMed and other resources. I can summarize it if chairperson they allow me with 3 minutes more. The aim of virtual reality glasses, there's different theory, and each day they have like the scientists, they have like a new theory talking about how virtual reality glasses working on human factors. So it's simply by distraction. There is a neurobiological interplay of brain cortex and neurochemistry, as well as the emotional and cognitive and attentional process will have an effect on brain. So we can summarize it, the effectiveness of virtual reality glasses. It could be used for acute and procedural pain and anxiety, and it could be used for chronic pain and neurorehabilitation. For acute and procedural pain and anxiety, it can be used in intravenous injection, vaccine, anesthesia administration, needle-related procedure. And they find there is a reduction in one of the study, there is a reduction in pain, 27 to 44 in pediatric patients. And they find that the tolerance for pain and the threshold is improving while using virtual reality glasses. For the second domain, which is chronic pain and neurorehabilitation, it can be used for neuromuscular-related chronic pain. Virtual reality offers an engaging opportunity for children to engage in active and repetitive motor and sensory practice, can increase neuroplasticity, practice motion that would be impossible or unsafe to be in the real world. Virtual reality training to improve balance in children with the cerebral palsy, especially after surgical intervention. Promote imagination, promote cortical repatterning, social interaction, and anxiety during casting, for example, for orthosis, virtual reality could be used. We need to consider the side effect as well. Visual-induced movement sickness, could be a contraindication like dizziness and nausea, collision with a nearby objective, and like any other social media could cause like social isolation, and in young children, possible potential for false memory. The home message that virtual reality is a new technology that offers a unique opportunity to modulate the experience of the pain. Virtual reality may assist in treatment of pediatric chronic pain as well as in some rehabilitation program. Before I finish my presentation, I would like to share with you a video for our experience in Sultan bin Abdul Aziz Humanitarian City. We use the virtual reality with our patients. This is my hospital, Riyadh, Sultan bin Abdul Aziz Humanitarian City. We are a rehab hospital. We are accredited from GCI, CARF, and other accreditation like Autobook and ISO. These two cases is post-surgical intervention. So for sure the patient, he will have like an anxiety, he will have like pain as well.
يلا شوف تعطيني اياها شوي. يلا كيف اللعبة؟ كيف اللعبة؟
حلوة.
ايش حاسة الحين؟ في شيء يعور؟ ها؟ كيف حاسة؟ تقدر تحركي رجليك ازين الحين؟ حركي شوف. فيهم شيء يعور؟ يلا. ولا شوي. كثير. كم واحد صوبتي؟ كثير ولا شوي؟
شوية.
يعني كم مثلا 5 6
أيوة.
7 مثلا 8
9 ايش منتبه هذا لا 10 كم واحد قولي لي؟ كثير ما شاء الله يلا كملي 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 كم تقريبا؟
يمكن 20.
اوه ما شاء الله بعد بدنا اياهم يوصلوا 50 شو رايك؟
فزت.
فزتي؟
ايوه.
خلصت اللعبة ولا بعدها شغالة؟
خلصت.
خلصت؟
ايه.
نشغل واحدة ثانية؟
عادي.
Okay. Right now you notice after it's finished she grab her leg. She feel the pain again. But while it's working she's not feeling the pain. Really here the VR distracted the pain from the
Thank you very much. Thank you very much.
Thank you, Dr. Abdullah, for this concise lecture, and the mic will move with Dr. Nafid Ahmed.
Thank you very much. I would like to call the last speaker of today's session, Dr. Baksh Sarwar. He is the co-founder and chief executive officer of Chal Foundation, Pakistan. He is a consultant to International Committee of the Red Cross in the field of physical rehabilitation in Pakistan. Dr. Baksh Sarwar, he did his postgraduate diploma from University of Dar es Salaam, Tanzania in prosthetics and orthotics. And he did his master in prosthetics and orthotics from Bufa, Germany. The lecture that he is going to present, it is about the need of trained personnel providing assistive devices, that is mainly prosthetics and orthotic services, in the rehabilitation of persons with physical impairment and disabilities.
Bismillah ar-Rahman ar-Rahim. I sincerely extend my thanks to the organizing committee and especially to Dr. Abdullah for giving me an opportunity to be here. Need of trained personnel. WHO Universal Health Coverage say to ensure that all people can use the promotive, preventive, curative, rehabilitative, and assistive and palliative health services they need, which are of sufficient quality to be effective, and also ensuring the use of these services not impose financial hardship on the user. Well, we mostly concentrated on the assistive. Assistive health services. What is assistive health service? WHO estimate that over 1 billion people need one or more assistive products for mobility, vision, hearing, communication, or cognition. This number is anticipated to grow to 2 billion by 2050. Everyone sitting in this hall will one day use an assistive technology. This is and after mobile technology, this will be a big change that the trade will be done in the assistive technology. Mobility assistive devices. Out of these other devices, the mobility assistive devices are prosthesis, orthosis, wheelchair, walkers, and crutches. These are the assistive devices which we use in the prosthetic and orthotics. Some of the who are the users? User of prosthetic and orthotic services are people in all walks of life who have physical impairment or functional limitation. For example, non-communicable disease such as diabetes, stroke, cancer, and peripheral vascular disease. Communicable disease such as tuberculosis, poliomyelitis, and Rowley ulcers. Injuries due to fall, road traffic and industrial accident, natural disasters, war and conflicts. Degenerative changes in the spine, knee, hip, foot, ankle, and upper limbs. Congenital anomalies or upper limb deficiency and cerebral palsy. What is the role of these orthoses? It enables people with physical impairment or functional limitation to live healthy, productive, independent, dignified lives, and to participate in education and labor market and social life. Their use can reduce the need for formal health care, support services, long-term care, and caregivers. Without them, for those who need them are often excluded, isolated, and locked into poverty, which increases the burden of mobility and disability. So these are the some how they use it. But luckily, WHO say only 1 in 10 persons who require prosthesis or orthosis have access to appropriate service. Why? High cost rate, lack of awareness, availability, financing, and a significant workforce shortfall exists in the field of prosthetic and orthotics, with a limited number of training programs around the world. So, for implementation in any country of prosthetic, you need 4 pillars. It is policy, products, personnel, and provision. So the 3 I will leave, policy, but I will concentrate on the personnel. To plan the workforce, you need the 4 steps. You have to determine the need for services in a country. You have to determine the need for personnel to provide those services. And then you have to profile what existing workforce you have, and you have to determine the need for training. Determining the need of services. There are 4 or 5 ways to determine. None of the country, even Saudi or Pakistan, they don't have the real number how many people in their country need assistive devices. So either we go to the journal estimate of WHO that every 0.5% of the population need prosthetic and orthotic services. Or you estimate need from data on the prevalence of health condition in a country. Or you estimate the need from a national census data. Or you estimate minimum needs from any service utilization in your country. Or you determine need in a dedicated survey. We must be very understandable the need versus demand. Sometimes the people go to a workshop or people go to a clinic and they say not many people. People who may need services do not demand them. Why? They may be not aware. Think the services could not help them. Think they are not entitled to the services. Or they are finding these services inaccessible. Or have a bad experience. Or unable to afford the services. So there is always more need than what we see as a demand. So now, what's the need of personnel? One is the services, and another is the organization of service system and units. The units, the geographical distribution in the country, either you are providing a centralized or decentralized services. What type of product you are providing? Different technology, different materials. Another thing is the knowledge skills of the people, whether you want a technical low-grade people or high-skilled people. And then how much finances you can provide to these. So there are these 2 types of things. Either you want exclusive prosthetic and orthotic approach, that the centers are the primary, secondary, and tertiary are outside the hospital or somewhere the workshops are. Or another is that inclusive that you are doing in the primary healthcare, in the secondary and tertiary. But in both, what way you require, from down to the, you need a simple people will be coming and going to complicate it. From down there will be frequent cases and up there will be rare. For example, club foot, polio, some cases which are difficult, they will be rare. So they will be coming to the tertiary. And so similarly, you need journal at the low and specialists at the top. Need of personnel now, how the International Society of Prosthetic and Orthotics classified the prosthetic. There are 2 types, clinician and non-clinician. You need both of them. Clinicians are the prosthetist and orthotist and associate prosthetist and orthotist. The non-clinician are the prosthetic and orthotic technicians. So the clinician, they have training level aimed at the full breadth of clinical service, leadership, advancing models, and or methods of service delivery. The non-clinician are the level aimed at technical design and fabrication of devices without providing clinical interventions. So these are some of the and after the training, they must go through a proper exam This is a board of examiner. So need of personnel, how it's, on average, a country requires 5 to 10 prosthetic and orthotic clinician per million population. In high-income countries, the number of clinicians is usually higher at 15 to 20 per million population, or more in some countries. In low-income countries, the number may be as low as 1 million population, but it will complicate the provision of sufficient service of appropriate quality. Non-clinician, each clinician is normally supported by 2 non-clinicians. So the country would need some 10 to 20 non-clinicians per million population. Increasing the number of non-clinician to clinician is an economical way and may be started because non-clinician you can train faster. In contrast, for specialized services, tertiary level or designated specialist clinic, a lower ratio of non-clinician to clinician, such as 1:1. Conclusion. Saudi Arabia, with a population of 34 million, needed at least 510 clinicians to serve the need of assistive devices in prosthetic and orthotics. However, you have only 40 to 50 people at present, and out of them, only 1 or 2 are female. This is the status of Saudi today. Similarly, at least 1,020, 1 to 2 non-clinicians to support the clinician in manufacturing and assembling the needed assistive devices. Here I don't know how much, there is one in Riyadh, if I remember, one course is going, but there is no now. And this is the only now you have started a clinician course. I'll just give 2 slides more. What is the prosthetic and orthotic service delivery process? The service delivery process has 4. One is the assessment, where appointment, assessment, prescription, goal setting. Second is the fabrication and fitting, where is measuring, fabrication, fitting in. Then number 2 is user training, therapy, gait training, training to acquire daily living skills. Number 4 is product delivery and follow-up, which means product delivery, outcome, follow-up, maintenance, and repair. This is how you set a clinic, that there is a service area and there is a stop area. In the service area, you have the reception, waiting area, clinical area, workshop area, and personal area. It's for these are the 4 books which are just in last year and even presented now in the Kobe in Japan. If anyone want to make in a country the prosthetic orthotic program, these 4 manuals give all the data, all the method, all the standards that you can follow. Thank you.
Excuse me, all lecturers attending for any questions?
شكرا لكم جزيلا. Thank you for all speakers. And as I informed from Dr. Abdullah, there is no much time, so we'll allow for some questions, 1 or 2 maximum questions, please. So any question, please, from any side?
اخواننا عشان ضيق الوقت حناخذ هذا السؤال بس عشان توكلوا على الله. Assalamu alaikum. Thank you for the great presentations. My question is for Abdullah Shami. What is the mechanism of pain inhibition with using the distraction tools such as VR?
Thank you very much for your question. As I mentioned, there is currently there is a lot of theory where justifying the reason and the the mechanism of the brain to manage the pain using virtual reality in simple way, which is distraction theory, which is well known, by having external stimulation for any stimulus. So this is one of the theory where could be justifying the virtual reality management for pain. But as per recently literature review, the scientists, they are still looking for a different theory behind the chronic pain. So they can find a proper management for different disabilities and different need for specific population. So right now there are no clear justification. There is some theory talking about cortex interaction, but there is still a lot by scientists to know the chemistry in the brain and what's happening well to justify the effectiveness on virtual reality on pain as well. Thank you very much.
Thank everyone.
Assalamu alaikum.
Sorry, I think there is no time for questions.
Okay. Thank you, Dr. Hamada, for your rich information in your lecture about the shoulder impingement. And according to Rasulullah sallallahu alaihi wasallam, قال اشتكى عضو تضاعف سائر الأعضاء بالسهرة والحمى. According to Dr. Steele from 1848, he said the whole body is one unit. And you said there is relation between the tongue and between the thoracic related to the shoulder. What about the rhomboid muscles? If the patient has tightened rhomboid muscles, will also affect it or no? Because you talk about biomechanics, about the clavicle and serratus anterior and the lower trapezius only.
Thank you for your question. Already I talk about the retractors muscle. Rhomboid is one from retractors. When there are weakness of the retractor, the activity of the rotator cuff will be decreased by 24%. If there are shortening of the rhomboids, will be make improper position of the scapula, which lead to impingement syndrome.
طيب شكرا يا اخواني جزيلا الخير. دكتور عبد الله. دكتور عبد الله.
دكتور خالد. دكتور حمادة. عبد الله خلاص ان شاء الله نتفضلوا على الغداء باذن الله تعالى. الاخوات في الدور الثاني والاخوه في الدور الاول، تفضلوا.